responsible and we take the interest in the academics. So at present, Dr. Jayaraman sir is working as senior consultant pulmonologist at MGM Healthcare, and he is a clinical lead at MGM Healthcare. He is also secretary IMA AMS TNSB, immediate past president IMA Chennai Villivakam and Ainavaram. So he has special interest in interventional pulmonology and sleep disordered breathing. Over to you, sir.
Thank you, Chairperson, Dr. Sridevi ma'am, Dr. Tilakavati ma'am, and Director of Internal Medicine, MGM Health. Very much. Over to Chairperson. Thank you, sir.
I think short and sweet. I think every time when a new drug is introduced, we think it is going to be a game changer. That is what we think. So when I went to ADA in 2017, this drug was semaglutide. The so-called Ozempic was introduced those time. That time we thought it's going to change the entire obesity management. Now we have got another drug. Though the semaglutide is available here as an oral preparation, injection is yet to come. The reason being the manufacturer is not able to supply to the Indian population because of the shortage. So that is why it has not come to the market yet, the injectable Ozempic for Indian market. So before we could blink, another drug has come, Tirzepatide, which is, I think, he has mentioned about all the trials that is connected with that. One is the Superb trial and Surpass trial, then now Surmount trial. All the trials have shown clearly it reduces the HbA1c reduction, and there is also reduction in weight reduction. The currently available drugs that I've been using, the Rybelsus, so-called semaglutide, is able to reduce 3 to 5 kgs. But whereas this Tirzepatide, they've already proven that it can reduce up to 14 kgs. It is going to be a very important drug that in the management of obesity in future. So we are all eagerly waiting for it. FDA has approved. And recently, another trial which came in, Dr. Jayaraman mentioned in December 24, it also prevents the development of type 2 diabetes. That's going to be an important drug in the prevention of diabetes mellitus itself. Are there any questions to him?
Good morning. Nice to see all of you on a Sunday morning so early up and after the walkathon. The spirit of this enthusiasm is from Jayaraman. I think he inspires the spirit in all of us. If not for him, I would have not been on the walkathon. Okay, thank you so much. Keep up the good spirit. Regarding Tirzepatide, I think what he mentioned is so true that it is a dual blocker and you can give it in non-diabetic patient. That's the main part. And what happens if your patient has not eaten or is fasting? It is glucose dependent secretion. That's the only thing. So if your patient eats, then the drug acts. If your patient doesn't eat, the drug doesn't act. So you need not worry about hypoglycemia. You need not worry about all those things. The second point I wanted to make is in OSA, why this study is so important. Weight reduction can almost cure your disease of in obese OSA patients. Weight reductions can help to almost reverse the disease also. So it's so important that we, like a patient who's not compatible with your diet and things like that, I think this drug will definitely be a game changer in that particular patient. So in medicine, I always say there is a place for every drug, every test, and every procedure. You have to find the right patient to give the right drug at the right time. So that's the role of Tirzepatide. Hopefully, it is a game changer. Let's see. Any questions from the audience, please?
Very nice and crisp talk, sir. But I think, because there's a new drug in the market, we should not be jumping. I feel to give it to all the patients. The first line of treatment still, I think, will remain the PAP therapy and weight reduction by natural means. And then only in patients who are not able to, lose weight or whatever, only those patients, I think we can try it out. And also the cost factor, when I was checking the net, so the cost of Tirzepatide, one injection is going to be close to a lakh, I think 80,000 to 1 lakh, I think somewhere around that. So not all patients are going to be affording this. So I think we should be choosing the patients wisely, as Tilaka ma'am has already told. We should be giving it to the right patient at the right time. Thank you.
Oh, sorry. So with this, we will close this session. And
So I invite Dr. Shivani Swami, the Secretary of CSM, to give the mementos first to the chairpersons. First to Dr. Tilaka, the HOD from Vijay Hospitals. Ma'am. I invite Dr. Shivani to give the memento to Dr. Sridevi from Jericare Hospitals. I invite Dr. Shivani to give the memento to Dr. Swami Kanna, HOD of Internal Medicine from MGM Hospitals. I invite Dr. Shivani to give the memento to Dr. Jayaraman, who is our first speaker, and he is the organizing secretary of the next International Sleep Conference. Yes. So we'll move on to the second session. This is a session on the management of OSC, a dentist perspective. I invite the chairpersons for the session, Dr. Bala Guhan. Welcome, sir. Dr. Manimaran M., pulmonologist from Mayat Hospital. Dr. Shanmugapriya from Lieutenant Bigai Medical College. And our speaker for today will be Dr. Pearlsit Siroraj. Welcome, sir. He will be speaking to us on the management of OSA, a dentist perspective. Usually OSA, we talk that it's going to be the forte of the pulmonologist, ENT surgeon when they do various surgeries, but we also have newer things happening from the dental department as well, and Dr. Siroraj will give us more inputs about that. Over to you, sir. Over to the chairpersons.
Good morning, everyone. I welcome Dr. Pearlsit Siroraj, sir, oral and maxillofacial surgeon, assistant professor from Ramchandra Institute of Higher Education and Research Institute. He is an oral surgeon with extensive expertise spanning over 10 years, specialization in complex maxillofacial trauma, TMJ surgery, and reconstructive procedure. He is currently associate assistant professor at Sri Ramchandra Medical College, and he did multiple prestigious fellowships, including FFPRCSA from Royal College of Surgery in Ireland, and he has more than 10 publications in leading international journals. He was awarded several competitive research grants, including ICMR research. And in the surgical front, he has performed complex surgery, including TJR of TMJ and panfacial fractures and complex dissection, osteogenesis for growing children. Over to you, sir.
So, good morning, all. So, first of all, I would like to thank CSM for giving me this opportunity and Jayaraman sir again. So, I'll be talking a little bit about OSA, maxillofacial surgeon's perspective. So, OSA, I mean, everyone here are stalwarts in OSA here. I'm just a novice here, and it gives me immense honor to talk in front of all of you experts. So, yes, so what is it? OSA, also called as Pickwickian syndrome, named after this character developed by Charles Dickens. So, Samuel Pickwicky. And it's just reduction in airflow, basically, simply put. So, that has to be addressed. Okay, so I'll be just talking about, yes, you're all going to be talking in depth about the lungs, the airway, and first I'll be talking about what we see and we commonly miss, the jaws. So prevalence, as we all know, it's got a lot of association with such complex medical disorders, including atrial fibrillation, type 2 diabetes, stroke, people undergoing bariatric surgeries, obesity. So all that is very commonly linked with OSA. So pathogenesis, these are all the common pathogenesis which will be dealt in detail, the first 4 Then comes the most important ones which are commonly missed. So the genial tubercle position or the hyoid bone position, the maxilla-mandibular position, and in case of people with temporomandibular joint ankylosis, this is something that we come across commonly. We do treat these patients widely, but we just don't associate them with OSA. So like I mentioned earlier, jaws, the position, it can be a retrognathic or a micrognathic. So all that has a significant role in altering the morphology of the airway. So what are all the risk factors for this? So again, age 40 to 70 years, obesity, craniofacial anomalies, which include a shorter maxilla with a narrow arch. So for instance, thumb sucking in a child. So that can also lead to OSA in an adolescent. Small retroprosed mandible, inferiorly placed hyoid bone. Coming on to diagnosis. So all these investigations, I'm sure all of you know about. So please add a lateral cephalogram as part of your investigation. So it is a must, I would say. So include a lateral cephalogram as part of your investigation. It's a non-invasive, very easily accessible, and very cheap investigation. So please do get this investigation as part of your screening for OSA. So I'll be showing a couple of images and how detailed a lateral cephalogram can give us the clinical scenario. So this was a landmark article by George Dimitroli, a very famous maxillofacial surgeon from Australia. So he has seen a lot of, this is something that we commonly see, something called as bruxism or night grinding habit. So this is something that comes to us dentists. Patient or the parents will say the son or the daughter is constantly grinding or the partner is constantly grinding their tooth at night. But we need to see the association of bruxism and OSA. And also that plays a crucial role in management per se. So in when we maxillofacial surgeons, we always treat OSA by repositioning the jaws. We either bring it forward or reposition, change the angulation and all that. So imagine if the patient is going to be a bruxer. So the force is going to be it is going to exceed the normal adaptability of your jaws. So imagine the jaw is cut in multiple pieces and it is repositioned, the legs are holding it. Imagine the patient is a bruxer. Your entire surgery is going to fail. So we should have it in mind, if the patient is going to be a bruxer, how are we going to treat that, and the association of bruxism and OSA per se. So this was another study where an MRI and a lateral cephalometry, this is how a lateral cephalometry is going to look on an X-ray. I'll show you an X-ray picture as well. So these are some values which they found significantly changed in case of a normal and an OSA patient. So this is your mandibular plane to hyoid bone. That distance was significantly more in case of an OSA patient. And this is what we call as an A and B angle. That was also reduced in case of an OSA patient. Whereas in case of an MRI, you can see the nasal pass and the mandibular posterior airway space as significantly reduced. So coming on to the management, the objective for treatment of OSA is going to be to completely eliminate OSA, to reduce the apnea-hypopnea index to less than 5 events per hour, to reduce the severity, to improve oxygen saturation, to alleviate symptoms, to address the sequelae of OSA, and to improve the quality of life. So these are the different types of management for different types of conditions. So it's going to be an impaired upper airway anatomy. If the anatomy is going to be distorted, address the anatomy. In that case, all the other stuff is not going to really matter. So this is a publication from our very own Vijay sir. Oh, okay. So we do have 3 different types of Fujita: type 1, 2, and 3. Type 1 is the purely retropalatal. Type 2 is where both retropalatal and retrolingual, and type 3 is laterolingual and hypopharyngeal. So yes, when do we do a surgery? When the events are more than 20 and failure of medical management, obvious anatomical site of obstruction is there clinically. This is exactly what I said. So as pulmonologists, before going into the airway, you start examination of the face. So first you look at the jaws, the tooth, and then we can go into the airway. So failure to tolerate CPAP therapy, oxygen desaturation, cardiac arrhythmias. So yes, to reduce the severity, excessive daytime. So basically to improve the quality of life, and also these surgeries will improve the profile of a patient as well, the looks. Right. So these are some of the surgeries that we have. Right. So I'll be just focusing more on the skeletal surgeries alone today. So first is expansion. Like I said, a narrow arch, which is commonly seen in case of thumb-sucking individuals, kids. So in those cases, the arch is usually narrow. So in those cases, we can go in for arch expansion appliances. So they increase the space available to accommodate the tongue. So that itself, so only a tongue fallback is again a very common thing, and that is associated. So if there is more space to accommodate the tongue, the events are reduced. Genioglossal advancement. This again, the insertion of the tongue is going to be on the genial tubercles. So we just make osteotomy, get the genial tubercles in front. So that pulls the tongue forward. So that way increasing the airway space. Again, like I said, imagine the hyoid distance between the hyoid and the mandible is more. In that case, again, there is going to be pulling of the tongue backwards. So in that case, we need to do some myotomy, or you can also suspend the hyoid at a much higher position. So this is our most commonly done procedure, mandibular advancement, more common in case of retrognathia or micrognathia. In that case, what we do is we just advance the mandible and pull it in front. So we can't just keep pulling. So we have our limitations of soft tissues associated. So up to 15 mm, we can directly go for something called as a bilateral sagittal split osteotomy. So we just perform an osteotomy of the mandible. We can take it all the way to 15 mm. The more advancement we do, the more relapse there is going to be, because the tongue is going to be a very strong muscle. It is going to pull it back. So we should have that in mind. And anything more movement, so severe advancement in case of kids or people with severe TMJ ankylosis, in those cases, we do something called as distraction osteogenesis. So maxillomandibular advancement, so a combination of both maxilla and the mandible. So imagine the problem is there only in the mandible. Why do we have to address the maxilla? So a lot of studies have proven when you do both the jaws together, or we call it as bi-jaw surgeries, that's more stable compared to a purely mandibular movement alone. So if I have to do 15 mm in a mandible alone, that's not going to be very stable. In that case, I can just do a little 10 mm of the mandible, 5 mm I can do on the maxilla. So systematic review that was published in 2018 says that it's got a very high success rate, over 86%, and apnea-hypopnea index has decreased from 63 to 9.5, increase in the quality of life, and reduce significant reduction in BP. Complication rates are very minimal, and there's no mortality associated. So like I mentioned earlier, so how much advancement can we do? So for maximal benefit, it has to be at least 10 to 12 mm. But again, if that is going to be more, the relapse rate is going to be higher. So you need to keep that in mind and then plan your surgeries. So yes, average maximum maxillary advancement is going to be 9.5, and average mandibular advancement is going to be 11.8 mm. So this was again a landmark paper published by Professor Neelam Andade from Mumbai. So she gave a protocol for managing complex TMJ ankylosis cases. So all these cases, the growth stops, the mandible becomes very small. So in that cases, what she did was two-step procedures. First, she did something called as distraction osteogenesis. So right. So first she did something called as bilateral mandibular distraction osteogenesis, wherein she gets the mandible much forward. Then she goes ahead and separates the ankylotic joint. Right. So this was the lateral ceph I was talking about. A very simple investigation. This gives this lateral profile of the patient. You can assess the airway. You can do all the measurements here, and it gives us a stable value of how much movement we can achieve. So you can see the significant improvement in the airway just by doing a distraction osteogenesis. Right, and for cosmetic purpose, we have some patients will have prognathic mandible. In those cases, we'll have to set back the mandible. So we ourselves can cause a patient can end up with an OSA. So in those cases, what we normally tend to do is we do put the jaw back and then we just do something called as genioplasty, get the chin in front, so that that kind of acts as an anchor point for the muscles. So this is the sleep study algorithm. So phase 1, when we have to do uvulopalatopharyngoplasty with a geniohyoid advancement or a hyoid myotomy alone. If that is not going to be curative, then we have to go in for maxillomandibular advancement. So I'll just quickly show a case that was presented to us. So a young individual. So he's working as a software engineer in the US. So he had tried multiple therapies in the US and yeah, CPAP. So everything's failed. So yes, he started acid reflux was first, and they really failed to diagnose this in the US. He was under treatment for a very long time. He was not really happy. So then he came down here. So we did go ahead and right. So we did an MRI sleep study. So he had an OSA at the retropalatal and retroglossal area. So is it visible on the screen? seen the pictures of the patient, if you remember, he had something called that, what we call an increased thin throat angle. So we see this angle is what we call a thin throat angle. So he had an obtuse angle. So that is again a clinical indicator of what to look for in a patient. So he's got some problem with the jaw. That's exactly the reason, or micronasia is what we call it. Those patients usually have something called as an increased thin throat angle. So we did see that in that patient. So if you can remember, so that is what it was. So we did 3D simulation. We assessed the airway. We did surgeries in the computer first. We do something called as virtual surgical planning these days. So how much movement we want in the maxilla and the mandible, we simulate that in the computer, and that also gives us how much airway improvement is going to be there. So we were able to see all that, and then we went ahead with the surgery. We did do jaw surgery. We did advance the maxilla and the mandible. Also did a genioplasty for the patient. His profile also improved. The patient had a win-win situation. So he had a better quality of life, better sleep, and also a good aesthetic profile. So the patient, we are just awaiting him another couple of months. So to run again, we are planning to do a polysomnography again for the patient, and also do a repeat cephalometric analysis to check how much improvement we have achieved. It's been a year and a half now. So we need to see whether is there any relapse for the patient. So probably next session, maybe I'd be able to document that better. So yes, make lateral cephalograms a part of your investigation. A very less invasive tool, very economical, hardly costs $500. So we can always get that done, and always check for the jaws and the tooth before going into the airway. So thank you all for this opportunity.
Good presentation. This is our last result for obstructive sleep apnea. If the non-invasive or semi-invasive procedures that is not going to help out, then the final thing it's going to come out with the maxillomandibular advancement or any genioplast advancement or any soft tissue or hard tissue procedures in the face. So this is the last result. Thank you, Ben.
Thank you so much, Dr. Palsad. I think apologies for the technical glitches, but actually he has given us an eye opener. Like as I had mentioned earlier, OSA we thought we dealt by the pulmonologists, maybe the physicians and the ENT surgeon. I think dental people have also planted their flag there. We are also there. That's what they've told us. Thanks for the inputs, Dr. Balagu, Dr. Shanmugapriya, Dr. Manimaran. Thank you so much. Please, sir.
About the recovery time, it takes usually a maximum of, I would say, around 8 weeks, maximum.
So if there are no further questions, we'll close this session. Thank you so much to the speaker and the chairperson. I invite Professor Chandrasekhar to please give the mementos to the chairpersons, to Dr. Balaguhan, oromaxillofacial surgeon. Invite Dr. Shanmugapriya. Please, sir. Dr. Chandrasekhar, sir. Neenga dhaan kudukana, sir. To Dr. Shanmugapriya, please. I invite Dr. Chandrasekhar to give the memento to Dr. Manimaran. I invite Dr. Chandrasekhar to please give the memento to the speaker, Dr. Palsad Chiroraj. you so much. So we'll move on to the next session, which is a panel discussion. Um, panel discussion is on steps to make sleep health a priority. This year's theme for the World Sleep Day at the World Sleep Society was make sleep health a priority. So we've got a panel of pulmonologists, we've got a physician, we've got psychiatrists on board to give us a discussion on what can be done to make sleep health much better on. I am Dr. Gayatri. I will be the moderator for this session and invite the two chairpersons for this session. Professor Dr. Srinivasan. Sir, please come to the dais, sir. Professor from Dr. Srinivasan, Professor from Meenakshi Medical College, Kandipuram. And I invite Dr. P.K. Thomas, sir, senior pulmonologist, well-known speaker at various pulmonology forums, sir, and also from MGM Healthcare, sir. Please come to the dais. And we have panelists. We've got Shivani Swami, madam, the secretary of the CSM. She is senior pulmonologist from Jaipur. We've got Dr. Kavita, physician with special interest in lifestyle changes and modification. Please, madam, please be seated. We've got Dr. Lakshmi Murali, pulmonologist, and she's the IMA president of the Rural IMA. We got Dr. Kaushik Muthuraja. Welcome, sir. He's a professor from Sri Ramachandra Medical College. And then we have Dr. Ramya Sampath, psychiatrist from MGM. She has special interest on subspecialty in adolescent and women mental health issues. Welcome to the panel. Please be seated. I request the chair to give a few words of introduction on the session, and then we will start.
Thank you very much, Dr. Gayatri. I think it's a pleasure and a privilege to thank Jayaraman for having given us the opportunity to get together. I think sleep is moving from the unknown to the known, in the sense that we're getting to know more and more of sleep and sleep-related disorders. There are basically two verticals in this that we can look at. The first vertical is, of course, the patient, the doctor who disseminates all the information that needs to be disseminated. The second vertical is the patient. And I think this is very important. And this doctor-patient relationship, this doctor-patient education that ultimately leads to the diagnosis of sleep apnea is something which is very important. And of course, today, to really look at it scientifically, we're moving from drugs to diet, for example. Diet is playing a major role especially in control of obesity, OSA, and also drugs. We are looking at a lot of drugs that are available today. But I think the simple public awareness, like this walkathon that was held in the morning, I think these are things that need to be emphasized over a period of time. These are things that spread the word around, and people around us in the community understand that there is something called sleep disordered breathing and a host of problems to follow beyond that. And I think that should be the awareness that we should create. If there's one thing that we do as a community today, is to send this message across and make sure that every single person is aware that there is an entity which is called sleep disordered breathing. Thank you very much.
I thank the organizers for giving this opportunity, especially Dr. Jayaraman and Professor Gayatri. As Dr. PKT has told, creating awareness among the medical fraternity first, then among the public. Yesterday, I witnessed one rally in a park, Trivika Park in San. There are a lot of gathering out there, and they made a great awareness among the public. The same way, we have got the panelists from different fields. I think they highlight the importance of sleep and everything. Thank you.
Thank you, sir. So this is a panel, I sort of designed it that it should be something which could be informative as well as useful for us in our day-to-day practice, because we have many patients coming to us with the various complaints about sleep and sleep disordered breathing. And we know how to diagnose a sleep disorder. We have a sleep study. We know what to do for it. We have to do lifestyle measures. We have to give an auto CPAP. Some of them might have to have an ENT procedure done or even a dental procedure done, as we heard from the previous speaker. But let's see how we have to counsel people and what more we need to know as people with special physicians with special interests in sleep disordered breathing. So this case capsule is about a three-membered nuclear family. Mr. X, he's 39 years old. He's a software engineer, works mostly on US timings. He leads a very sedentary lifestyle. He has gained about 15 kilos of weight over the last 5 years. He's a diabetic, he's a hypertensive, and he's a smoker. He has disturbed sleep at night. He snores, he feels very tired in the daytime. For all these complaints, he had consulted the company doctor who later referred him off to a sleep specialist. They investigated him, they did the basic workup for him. They found his cardiac function was normal, chest x-ray was normal, his echocardiogram was normal. Finally, with the symptomatology, they found out based on a sleep study that he had obstructive sleep apnea, and they put him on auto CPAP. But the patient has not been very compliant. So that's our index patient. Then we have his wife, Mrs. X. She's a 36-year-old lady. She's on treatment for hyperthyroidism. She gets up every day in the morning at 5 a.m. to start her daily routine and goes to bed around 11 p.m. But she has a lot of difficulty falling asleep. She constantly feels tired and she's irritable. And sometimes she uses sleeping pills to fall asleep. And they have one child, Master X Jr. He's a 13-year-old teenager. He's overweight. He's more into PlayStation and all such activities rather than playing outdoors. So more of an indoor person. He sleeps very late. The teachers have complained that he keeps falling asleep in school. So parent-teacher meetings have not been very fruitful. So we have this session where we need to discuss how do we proceed with this kind of a scenario and what are the common problems we face with patients reporting with these kind of backgrounds. So when the world has expanded, our working time is no longer 9 to 5. It is actually, depends on which shift you're working, which country time zone you're working. So the world never sleeps. So the question off to Dr. Shivani Swami. When the world never sleeps, what's the impact of working on different time zones on the person and all the shifts on sleep health?
Good morning, everybody. I'm very, very glad and happy to be here. And thank you, ma'am, for the question. So we need to understand that ma'am has correctly said that, of course, the world never sleeps. And that's what we are getting to. And if we look at the statistics, 1 in 20 of the adult working population is actually, so 1 out of 20 working adults is actually working in a shift. And 1 out of these 20 is actually bound to probably at some point suffer from the shift work disorder. So that's exactly how common it is, and still very little is known about it. So my question basically is about the health hazards of shift work disorder. So we need to understand there are going to be multiple types of shifts that a person is going to go into. So there are going to be rapid shift changes, there are going to be late shift changes, wherein people are probably moving from one shift to another, not at a very slow pace. So maybe one day he has a morning, the next day he has a night. So that is a rapid shift change. Then there is slow shift change, wherein probably 1 week he's working in a morning shift and then is gradually next week moved to a afternoon shift. So, and of course, then there are going to be people who may not actually have any fixed schedule of their shifts. It may be very, very random. So all of these together are also going to affect the individual equally. And rapid shift workers are going to be less affected compared to people who have no schedule or are being shifted very quickly. So having said that, when we look at the health hazards, of course, the health hazards of any sleep disorder wherein we are depriving ourselves of not just quantitative but also quality of sleep more or less remain the same. Of course, increased risk of cardiovascular deaths, increased risk of diabetes, increased risk of hypertension, arrhythmias, and then most importantly, with shift work disorders, what really stands out is increased risk of a lot of cancers. So that's where we are at. And so this is a huge number where the a vast population is actually suffering from these diseases, and we don't even know that probably shift work is what is practically causing it, or at least instigating this. So definitely awareness needs to come out for this as well.
Thank you, ma'am, for your insights on that. Because number of patients who are coming in for our consultation nowadays, they do report that they have a lot of sleep disturbances, especially on the shift duties. And many of the, I would say, BPO workers and software professionals, they are working in various shifts and time zones. So earlier, I would say would have been a point of prestige. Okay, you're working on US time or UK time, but now it's going to be a detrimental impact on their health. When they are younger, it's much better, but as they creep to a higher age, it's going to be more and more difficult. And with this lack of sleep, and that's where we really come in. What's the significance of the sleep deficit and the sleep deprivation on the well-being of a person? Because the software engineer index patient, he was not sleeping so well, obviously living in India, but working on US timing. The wife also was getting up earlier in the morning, sleeping very late, not sleeping so well, was very irritable in the daytime. So, Dr. Kaushik, how do you really find that? What is the impact of the sleep deprivation and sleep deficit on the well-being of the patient? What would you like to counsel the patient, and how would you really approach this scenario in your practice?
Thank you very much for taking me in the panel for this sleep discussion. I think when it comes to sleep deficit and sleep deprivation, and what is very important is to understand what is the amount of sleep each individual requires, and if they're able to achieve that many of hours. If they're not able to achieve that many of hours, then probably they are going into a sleep deprivation or sleep deficit, which on a if it becomes as a continuous or a day-to-day process, then there is a lot of health risk associated with it. One direct risk which is associated to it is physical injuries or vehicle accidents, which can happen because of sleep deprivation and sleep deprivation. The other indirect impacts happens is basically to your physical health and to your mental health. When it comes to physical health, it causes sleep deprivation causes an inflammatory condition in your it actually cause an pro-inflammatory phase in your body, so thereby worsening the diabetes or hypertension, and it can also precipitate cardiac events. And then second is it actually brings down the immunity, and then there will be a lot of effects that includes less immune status, and then and the very important thing is the mental health thing, which it affects, including mood disorders, and then it also causes forgetfulness, memory loss, and then less attention span. So I think all these has to be discussed with the patient who is actually going through such either it's shift work or patient or people undergoing actually suffering from sleep deprivation due to any manner. I think that's the discussion told clearly that these could be the long-term effects which can be which they can be bringing up from the
Okay, excellent point, Dr. Kaushik. Thank you so much. See, this is something which, as doctors dealing with sleep disorders, or physicians who are dealing with patients coming in with all these complaints, we really need to stress to them that this kind of sleep deprivation happening over many days, over many years, is going to have a serious impact on the cardiovascular health, on the immunity, and it's a pro-inflammatory mechanism which can lead to other health hazards. So that has to be emphasized, because many a time I see patients, they are not bothered so about their day-to-day activities, about health, because this session was basically on sleep timing as a health priority. So that's why this important stress on better quality of sleep and better timing. So when we talk about patients who are not sleeping because of various factors, I'd like to ask Dr. Ramya, who's a psychiatrist, what do you feel about this insomnia? Do you think it's just a sleep-related disorder, or do you think it's a pointer towards depression? Because many of the patients keep telling us, okay, I can't sleep. So because most of the patients may be maybe the 65 plus population, they might tell they can't sleep, they might have to pop a pill, or they are too stressed out and they can't sleep. So what do you feel, Dr. Ramya? Do you think it's only sleep related, or could there be something else underlying that we have to pursue further? Do we start earlier psychiatric referral? Is that required, or do we do it later on the schedule? What? Please share your inputs.
Very good morning. Happy to be a part of this esteemed panel. Very valid question, madam, in the context that many times insomnia or sleep disturbance is commonly, it can be an independent entity. The Diagnostic and Statistical Manual, which is our diagnostic manual for psychiatrists, we call it insomnia as a disorder when the person reports disturbance in the quality or the quantity of sleep. And it is very persistent, like at least for 3 nights in a week for at least 3 months, which is sufficient enough to cause a significant impairment in the functionality of the individual. And it is also equally important to understand insomnia can be a standalone diagnosis. Also, it can be a presentation of a varied spectrum of other health conditions, common conditions, physical health, concerning physical health like anemia, hypothyroidism, any other medical problems that involves chronic painful conditions can all have insomnia as a very clinically distressing complaint. We may be bothered about something else, but for the person subjectively not having a good sleep is very, very distressing on the distress scale. Insomnia can also be a part of some other psychiatric diagnosis like anxiety or depression. So commonly people with anxiety will have difficulty in falling asleep. So usually it will be the initial phase of insomnia at the start. So sleep onset will be more difficult for an anxious person. Whereas for the population who is clinically depressed, insomnia usually presents as early morning awakening. That is, this is my usual waking up time. I start getting up 2 hours earlier to my usual time. So this is early morning awakening, which is very classical of a person with depressive syndrome. So insomnia is a standalone diagnosis or a primary insomnia. We can only entertain that diagnosis when we have ruled out all other possibilities in which insomnia can be a symptom manifestation. And it can also be secondary insomnia, where it is related to some other physical or psychological condition. It is equally important to remember or to understand the person should have adequate opportunity to sleep. For example, in the cases that we saw, when there is no adequate opportunity to sleep, for example, in the case of a shift work condition, or when somebody has to finish targets, or there's an upcoming exam, there is no ideal environment to fall asleep. So in such situation, insomnia diagnosis cannot be entertained when there is no opportunity to sleep only. So insomnia as a diagnosis can only be entertained when there is adequate opportunity to sleep. Also, the clinical presentation is consistent and it is causing clinically significant impairment.
Yes, thank you so much, Dr. Ramya. See, basically what she has emphasized when the patient tells you that, okay, I can't sleep, it's not that you just prescribe a sleeping tablet and be done with it. I think you need to get a detailed history about the patient, the lifestyle, the job, the family environment. So everything makes a big difference in the diagnosis and how we would approach it actually. So then going on to the younger generation. So the question off to Dr. Kavita. What's the downside in the sleep habits of the present generation of children and young adults? So what do you feel? She's a physician with special interest in lifestyle modification and lifestyle diseases. Your inputs, please.
Thank you very much, madam. I think more than a panelist, I'll be part of all of you here to answer this question, because we all have everybody at home with mobiles at night in their hands and postponing our sleep time, right? Not only doesn't stop with youngsters, I believe, I hope you all accept, at least within yourself, all of us are very human enough to become a little bit addicted to the screen. right? So the same goes to the younger generation, but only thing is they have lots to do, they have lots to prove, and they have lots to learn and go ahead. And of course, we will be, as a parent or as a caregiver, we will be getting complaints from the academic aspects as well from the school with regards to the lower performance or cognitive impairment, sometimes even behavioral disturbances from the childhood or the young teenagers also. As you all know, teenagers have their wiring very different, and they already have enough problems because of their age. And as the puberty sets in, what happens is the circadian rhythm also changes to delayed phase disorder, where because of social commitments and peer group pressure, all these youngsters have to be awake for a longer time than the usual time, and they find it very difficult to get up in the morning to go to the school or to fulfill their academic requirements. But what, as physicians and as parents, as somebody who takes care of all these things, we have to give them some solutions rather than talking about this also. My first request to all our physician fraternity to include sleep history whenever you deal with a client. Please at least make the 3 valid questions with regards to your going to the bedtime, getting up time, and the freshness when they get up, and also if they do have some excessive daytime sleepiness. See, all these things points to many important physical morbidity causes that could be the point of finding whenever you have a client in your clinic. And the next thing is, when a parent comes to you with the academic performance, please make a note of sleep history or their emotional disturbances, because the sleep disturbance eventually leads to ADHD, anxiety related disorders, cognitive impairment. All these needs to be put back because the child has to grow and become a very responsible young adult. Okay. The next thing is, as a public, please, as you all think, or even as a common myth, sleep is not rest. It's a very active process which is going on in the brain for lots and lots of maintenance. It's a very where your memory gets consolidated, your immunity system is put back to its original shape, and also your cognitive senses. So lack of sleep has definite uh, repercussions on all these aspects. So just simply make 3 things to this client, whoever comes and whatever may be their age, to maintain 3 things. One is the regularity of your sleep time, the getting up as well as the going to bed sleep time, and your quality of sleep. So the efficiency, sleep efficiency is much better, and you are back to your original and your productive self within that. And I think the same applies to all as individuals also. And we all have to take the responsibility for our own health with regards to sleep health. Thank you so much.
Yes, thank you, madam. I think she's reiterated the point. Charity begins at home. So we should start with first treating ourselves with our various problems which we might have with the sleep and poor sleep hygiene. So Dr. Lakshmi Murali, she is a practicing pulmonologist at the Peripheral Center at Thiruvallur. Madam, what are the common sleep-related breathing disorders you encounter, and did you find any gender differences noted when treating your patients at the Peripheral Center compared to what was your experience from the city?
First of all, thank you for the opportunity to be the panel member here. Actually, the peripheral health sector, we are coming across the cases like insomnia, restless leg syndromes, and obstructive sleep apnea, and excessive daytime sleepiness, etc. But these are among the gender-wise, it was underdiagnosed in the women. Though they are in the women, they are more prone for ED, that is excessive daytime sleepiness, obstructive apnea, and all. But it was underdiagnosed. And as usual, the women, they won't tell their that is sleep complaints. Whenever they are come for some other complaints, and they are boarded with that complaints only, and they are disclosing their sleep disorders in them. And especially the insomnia and everything is because of the hormonal factor in among the men. It was more because of the that is the progesterone and estrogen and other hormones and all. So hypothyroidism, that and all makes a payment for the underdiagnosed among the excessive disorders in the sleep disorders in the women. And regarding the pregnancy also, the restless syndrome is more common in the pregnant women. And as the age advances, especially the menopause, these are all very common, the sleep disorders. And regarding the time period among the women, starts with the adolescent age, PCOS, and these periods and all, the lifetime modification, they are not able to cope up with and are landing up with the sleep disorders. And so these are the main thing. The women are getting, though they are getting more sleep than men, but it was not the quality one. The sleep efficiency is not there. So we have to concentrate much on the women side also. Recently only we have celebrated our Women's Day. So at least some attention to the women also we have to give them. And most probably among the gender, both men and women, we have to, whenever the health, making the health priority, we have to do the awareness, like today morning walkathon is there. Like that, we have to do the awareness so that in the periphery center also, let them have the thing of what is the sleep and what is its importance. Otherwise, just they will say just sadharana koratadane. So we have to concentrate much on them, the periphery sector, when we are come across to the periphery center. Thank you very much for listening.
Thank you, Madam, for sharing your experiences on the sector which we are, as city physicians, we are not very well aware of. So just going on to the last set of discussion, question off to Dr. Shivani Swami. When we talk about all those patients dealing with the shifts and night shifts and all that, one of the questions my patients keep asking me is, how am I supposed to use the auto CPAP? You tell me I have to do it overnight, but I'm working overnight. So when I come home in the morning, I do my stuff, I don't sleep much. So where do we fit in the auto CPAP there? So this is a practical question. Madam is an experienced pulmonologist from Jaipur. I think she is the best person to answer this.
So actually very practical problem that people do face, ma'am, as you correctly pointed out. And my advice to these patients is that whatever time they're sleeping, that is when they should actually be putting on the CPAP. However, it is definitely more challenging for patients of sleep apnea and concomitant shift work to be able to cope up with that, because of course when they're sleeping during the day after working at night, their requirements of pressures might actually change, because they might actually have less of REM sleep when they sleep during the day. So that is something that we must really be very conscious of. So these are patients who may not actually be good candidates for a basic CPAP, and or if they have REM associated sleep apnea, what they need is basically auto CPAP. So also they might actually find it more difficult to go to sleep after the shift. So that is again a problem for which we need to explain to them in detail. They also might actually feel more sleepy when they go on to their shift. So there are certain things that we also need to tell them, like in the first part of the shift, if they can be exposed to brighter lights or blue ray lights, it might actually help them be awake. We could also use pharmacotherapy, so maybe things like caffeine actually helps them keep them awake, or modafinil or armodafinil, so very limited indication of these drugs. One of these indications is this, to keep them awake while they are going on to their shift. And in the second half of the shift, we ask them not to have any CNS stimulants like caffeine or tea or smoke. And of course, try and limit their exposure to bright lights. One very important thing that we must tell these patients is try not to drive back home from when their shift gets over. So these are things that we must really tell these patients, and it might actually help them regulate their sleep in a much better way.
Yes, thank you, ma'am. Very insightful advice for all of us, actually, because when we talk about only seeing the patient, getting some questionnaire filled and doing a test and prescribing the CPAP or auto CPAP, there are so many things behind the scenes, actually, which really needs to be done for the success of the treatment and protocol. Thank you so much, ma'am. Dr. Kaushik, I just want to know, with so much of smart technology, smartphone, smartwatch, smart bed technology, do you think all those sleep trackers are going to make us sleep better, or are they going to worsen the situation? I feel Dr. Kavita has told us it's going to worsen the situation. But what are your views on that?
I think we should actually look at selecting the right population for recommending such sleep tracking devices, especially patients who do not have access to a better healthcare facility, and then who cannot meet a sleep specialist on a regular basis, but then they need a large amount of data to analyze on a day-to-day basis how the sleep pattern is. I think that is where these sleep trackers actually come handy. But then it is definitely not a replacement to the regular sleep study at any cost. Sleep study is the gold standard. We cannot take sleep trackers as a data from the sleep trackers and treat any patient. But then where it actually helps is it actually documents the patient's sleep duration. But then what technology most of these things use is basically the body position or the patient's movement. So that is what is being analyzed. And certain trackers also analyze what kind of environment the patient is in. And then if there is an app attached to it, then probably they can log in what kind of lifestyle they are following, whether they're doing any kind of activities which would disrupt the sleep. So I think it is a very good tool to maintain a sleep hygiene and a sleep regularity. But then other than that, when it comes to enhancing sleep as such, I don't think they have a very solid role as of now. And then a lot of gadgets which are available, they're also not certified or accredited by good medical bodies. I think that should also be considered before choosing these sleep trackers.
Yeah, thanks, Dr. Kaushik. So we still have a job in place. So totally we are not going to be jobless because of all this AI coming in. So Dr. Tamya, what do you feel about this cognitive behavior therapy? Does it really help in the management of insomnia? Is it going to be something which you recommend for your patients, or you're quite selective on those CBT therapies for your patients?
When we come to the diagnosis of insomnia, so cognitive behavior therapy for insomnia is definitely recommended, and studies have clearly shown that it at least improves some aspects of sleep to at least 60 to 70%, which is very significant. So basically, cognitive behavior therapy for insomnia, it is focusing on the cognitive restructuring centered around the client's thoughts, feelings, and behaviors in relation to the sleep pattern. So somebody might have a lot of cognitive schema distortions. For example, there are people who are so obsessed with getting that 8 or to 8.5 hours of sleep. If they sleep for 7 hours, they get so panicky. They just immediately ring and say, I haven't slept well. How can I manage through the day? What am I supposed to do? So that kind of cognitive distortion related to how sleep affects the overall functionality, we do see some clients on this extreme. On the other hand, there are clients who are very negligent about their sleep quality. It is okay, doc, if I don't sleep, I'll have a coffee or tea and I'll just push on for the day. So on both angles, both of these things are detrimental. So in cognitive restructuring, basically we are trying to educate the client on how their belief systems are actually influencing their sleep pattern. So an obsessed client can go to bed and then keep looking at the clock. Okay, it's 10 o'clock, I haven't got my sleep. Will I get my sleep at 10:30? So what am I supposed to do? So you get so anxious that actually sleep is a very passive thing that is supposed to happen. So because of active processing of the brain, the sleep is getting actually postponed. So these things are addressed in cognitive restructuring. And from the behavioral aspect, there are a lot of techniques like stimulus control, sleep consolidation, and relaxation techniques, which offer clear benefit for the client. So, for example, stimulus control is a lot of times we know that we all have a clock and a TV as a part of our bedroom. So which is very unhealthy. So the first thing that we tell our client is it shouldn't be there. The gadget or the TV or the clock shouldn't be there as in your bedroom as a thing. So what will happen is it's very natural for a client with insomnia to use the bed for any other reason, like they eat their dinner watching the TV sitting on the bed. They chat over the phone or use their laptop sitting on their bed. So the bed should be used only for the purpose of sleep. If they are not able to fall asleep in 10 minutes after going to the bed, they need not get worried about it. They have to get up and go to the living room and do something offline, like read a book or just listen to some song or engage in some passive activity unless the sleep takes off. So this is basically the stimulus control. And sleep consolidation is, lot of times people try to catch up with the sleep, saying that they haven't slept well. They were just tossing in the bed for 2-3 hours at the bedtime, so they don't get up early or the usual waking time. So what eventually happens is the sleeping time or the bedtime gets spilled over like 14 hours or 15 hours. I just keep lying in the bed the entire day, entire time of the day. So that shouldn't be encouraged. They should use the bed only for the purpose of sleep, and only for that 8 hours or 8.5 hours or 7 hours or whatever they are trying to achieve. So that is sleep restriction or consolidation. And relaxation techniques like muscle relaxation, guided imagery, mindful breathing techniques. These techniques are very helpful in helping early initiation of sleep. So when we teach the client the right way to the bedtime routine and engaging in a relaxation routine, the brain gets tuned. So it is like you are getting the yellow signal before the red light. So similarly, the brain gets primed. So the melatonin synthesis, the consolidation, the quality of sleep is much better. So these are basic things in terms of cognitive behavior therapy for insomnia, which can be tried in all clients, because definitely non-pharmacological techniques cannot be ignored when we are dealing with a client with insomnia.
Yes, thank you, Dr. Ramya. So there's a lot more to management of insomnia. Thanks so much for the other inputs, for letting us know about CBT. Dr. Kavita already has mentioned a lot of tips on how to sleep much better. Madam, would you like to add anything else to how can you sleep much better?
As somebody who can follow simple things, I would like to put forward a small thing which is coming up recently. It's 8-3-2-1 concept. Okay, you need at least 8 hours of sleep. See, at no age the sleep requirement does not change. It remains the same. We only make alterations, like 6 hours is enough, 4 hours is enough. It's not so. So it's 8 hours of sleep at least we need. Okay, and maybe you can, as your profession or as your demand goes, you can make one. The next thing is 3 hours. That is 8-3. 3 hours before you go to bed, kindly finish your dinner. See, all what you can have, please finish it at least 3 hours before you go to bed. That is very important, because the thing is highly related to your gastric secretion, emptying time, and all your intestine secretions. So please make it a point to finish your dinner. Whatever time you go to bed, make sure you do it 3 hours before you hit the bed. The next thing is 2 hours. This is, you can have a warm shower or a warm liquid or something which matches your routines 2 hours before your sleep time. And 1 hour before, kindly stop all your screen time. That is very important to have a very good quality of sleep. That is what we all want. This is not from any WhatsApp university. This has been closely linked to the hormone cycles which are there in our sleep cycle. For example, melatonin and your basal body temperature. That's why a warm shower 2 hours before sleep helps you a lot, because the maximum body temperature is 2 hours before you go to the bed. And 2 hours before you get up, the minimum body temperature is the one at which actually also wakes you up at the right time. And your melatonin secretion, it's also linked to 2-3 hours before you go to bed. So when you wind up, when you start preparing your mind to go to your resting time, that is also a very important thing. And as you all know, gadgets, please keep them aside at least 1 hour, and bring back your reading habits of black and white. That is your book or your literature. But kindly avoid newspapers and any crime thrillers, which can again put your mind very active. So go to some soft things which will make you some motivated things, or maybe some light readings which you would have been putting for a very long time without any proper time. Don't take this good sleep time for doing something better, because sleep is always the best. You have to catch it. Thank you.
Thank you, madam. Excellent point. 8-3-2-1. Okay, this is something which we should keep, that magical number. So we will finish with the final thing, Dr. Lakshmi. What are the tips for the medical professionals to prioritize our sleep? So this is something for us. So, madam, we've told all of us, okay, keep our phones off. I think I should start from with my learning point, I would say.
So actually, professional tips are actually Dr. Kavita told already the 8321 points that the professional has to follow that also. But regularize our sleep because when we are taking the doctors as a professional, they are because of the highly competitive this thing, they are going for a lot of work in the after their time schedule also, and the post duty off is given for the rest only. But in that too also they are going for the thing, and they are making their because of the want to earn, they are going for a lot of thing without taking any rest or sleep. So that should be given and given importance. And first of all, our aim is first to make our sleep as a priority, then only we can do our things better. And we have to concentrate mainly on the that is diet and exercise. Early morning walk is in the sunlight, that also helps us to get our mind free of all the thing, and we get some calcium this thing also. So early morning walk is very important, and a little bit of concentration to the yoga and meditation, because our mind will get relaxed, so that we will get the good sleep. And regarding the diet also, tryptophan producing drugs like the food like milk, cheese, nuts, that and all to be apple, honey, that and all to be given importance, and we have to take. And the thing is that the 831 they already told. So to make our things, make the tips, then the professional wise, we have to concentrate our health also. When we are getting the good sleep, we'll do our best thing. And thank you for giving me the opportunity.
Thank you so much, Dr. Lakshmi. I think that is something, a message for us also. We are treating patients, but I think sometimes we have to look inwards and make sure we also are supported well and take care of our health. And would anyone from the audience like to ask questions, please?
Good morning, everybody. So, my regards to the panelists who are talking much about sleep and everything. So, a patient comes to you with a sleep disorder. First, we have to analyze the sleep study pattern, how the sleep study goes on, how much hour, what is the quality of sleep he has, whether he's having a proper REM, that's REM sleep, non-rapid eye movement sleep, and REM everything, and how long the deep sleep is going on, and however the thing is analyzed. When coming to our specialty, I am a dentist, pediatric dentist working in Tagore, so I'm heading the department. When people come to our department, we see after the sleep cycle, any obstructive pattern are going out in the mouth. Okay. Ma'am said neurocognitive effects of psychology in development. Sir said metabolic diseases. Pulmonologist said lot amount of metabolic problems are there and everything. So we are in the department, we are conducting a research mainly about tongue tone. The tongue tone which manages all the velopharyngeal phase, everything. See, when the tongue tone is not proper, the fall back of tongue to the velopharyngeal and obstruction is more. In before 2008 and everything, the lifestyle changed completely. When the period of mobile came, the tongue tone also reduced and causes obstructive. The cases of obstructive sleep apnea has emerged a lot in pediatrics. Okay, Dr. Paulson said about a lot amount of surgical things. When coming to pediatric sleep apnea, we see about the tongue tone and the expansion and the growth. See, the norm, actually the breathing pattern mostly depends upon the nose and the mouth. How you breathe to the nose and the position of the tongue maintains the sleep pattern very well. So my regards is to see the tongue tone and the palate form in sleep patients much helps better in diagnosing in a future things. See, all these patterns, whatever the psychological problem, pulmonary problems, what are the metabolic problems and everything, these are the side symptoms. We have to clear the obstruction first and then move on to maintain the child to breathe properly or a man to breathe properly and everything, and then go on with the proper treatment protocol. See, many patients will not accept CPAP immediately. I have seen. Go to get a CPAP, put it in the mouth. They won't use it because the tongue pattern and the velopharyngeal pattern are different. The obstruction pattern will be more. So kindly correct that, and then we can go for the CPAP appliances. See, I might be out of your field. I'm a dentist, pediatric dentist. Sorry, any wrong things in my comment, can you kindly... Okay, thanks for the opportunity.
Yeah. Thank you, Dr. Gayatri, for putting up a wonderful show. It was an excellent panel discussion, and all of them contributed important points. My question is to Dr. Shivani. So all the panelists kept on talking about 8 hours of sleep. You need to maintain the number of hours of sleep. So for a person like me, I can sleep only for 4 to 5 hours, but I feel very fresh in the morning. I'm 200% potential is there for me. So my question is, does the quality of sleep matter or the quantity of sleep matter? What is your take? So, thank you, ma'am, for the excellent question. So, I do agree with both the points that 8 hours of sleep is required, but then that is actually not the thumb rule. For an average person, 8.14 hours of sleep is needed for an adult. However, there are physiological changes associated even with that number. When a child is born, a neonate actually sleeps much longer than 8.14 hours. And as we grow older, the geriatric population is known to have less of sleep. And of course, there are changes even in the quality of sleep and the sleep stages, which are physiological and acceptable. So very often when a geriatric person comes to us saying that I have not been sleeping, I only sleep 6 hours. So I think all we need to do is reassure them that this is normal. If it is not affecting your daytime functioning, it is absolutely normal. And even from an individual to individual, there is, of course, a varied requirement. Like I think our PM also does sleep for only 4 hours. So I think it is a person to person variation also which exists. And at the same time, I would also like to break the myth that we have this myth. We keep teaching our children sleep in time, wake up in time. We also need to understand that there is a different phenotype. There are people who are morning larks and there are people who are night owls. So that is something that is there in their genes. This is not something that we can change. And we are actually pushing a night owl to work, get up in the morning, go to school. That kid's productivity is definitely going to be much less as compared to. So that flexibility somehow actually has to come into the society. So I think those are things that we must really keep in mind.
Then what do you suggest for senior citizens, ma'am?
So sleep pattern is something, ma'am. If any amount of sleep is not affecting their daytime functioning, then it is not pathological. If they are waking up fresh, they're able to pull through all their chores during the day. They're not feeling tired, exhausted, do not have sleep inertia, do not have morning headaches, then it is definitely not pathological for them.
Yeah, yes.
See, there are, by ICST classification itself, there is a classification called short sleepers. See, if, as ma'am told, if that's not affecting your regular routines or cognitive functioning or anything, that is okay. There are few people who are having that is almost less than 6 hours. ICST classification mentions it specifically for long sleepers and short sleepers, and it is okay to be so. But you have to rule out all other disorders of sleep to say that it's a ruling out diagnosis, to say that you are a short sleeper and that's not going to affect you. Thank you.
Thank you all the panelists and moderator for excellent discussion. Just actually, I want to add to my dental friend. Actually, what he said is absolutely correct, because the reason for this low tone in the tongue basically is nasal obstruction.
because when there is a nasal obstruction, hypoxia, naturally the muscle tone comes down. So that is one of the reasons. Just I want. Then I have a question to Dr. Lakshmi or a suggestion. Actually, I have seen in most of the cases, the mobile addiction is more with the male in the younger age group, whereas in the older age, probably it is almost equal. I would like to know your opinion, because that is another thing. And regarding the this night duty, this problem, I would suggest, I think we all should recommend, actually, even for securities, in nursing in a private hospital in Kerala. I am from Trivandrum. My name is John Panika. The night duty time is actually 14 hours, starting from 6 to 8 o'clock, whereas the daytime is actually, what I feel is the night duty should be half of the day duty. So something similar, we should, at least they will get a 4 to 5 hours of night sleep, which is entirely, definitely is better than having 10 hours sleep in the daytime. That's what I feel. So I would get, yeah.
Regarding the mobile usage in the youngsters, they are using a lot, and even in the old age also, we have to keep our work going on. It is time to see the thing or the mobile also, but as soon as age advances, we are getting less of sleep only. So in that particular timing itself, we have to close our, after finishing our, close our gadgets, and we have to sleep. Then only we can have our sleep, a nice sleep without any mood affection or anything.
Yes, thank you so much, panelists and chairperson, for this and the audience interaction for this wonderful session. With this, we will close the session. I invite Professor Mahil Maran sir. Sir, can you please come and give the memento to Dr. Srinivasan sir? Thank you so much. Mahil Maran sir, can you please give the memento to Dr. Shivani Swami, madam? Huh? Ramya. Sorry, to Dr. Ramya. Dr. Mahil Maran, please give the memento to Dr. Kaushik. Request Dr. Mahil Maran to give the memento to Dr. Lakshmi. Request Dr. Mahil Maran to give the memento to Dr. Kavita. Request Dr. Mahil Maran to give the memento to Dr. Shivani, madam. Thank you so much, Mahil Maran sir. Over to Dr. Jayaraman.
Now we'll have inauguration functions. So I request the chief guest, Dr. Shivani Swami, please come to the dais. May I request the Association of Pulmonologists of Tamil Nadu's President, Dr. Chandrasekhar sir, please come to the dais. I request Mahil Maran sir, please come to the dais. Dr. Tirzepatide ma'am, organizing chairpersons of our CSM conference, please come to the dais. So we'll have a lighting Kuthuvalakku. Muttarasan, call the boys. Now lighting Kuthuvalakku by our chief guest. I request the Gayatri ma'am, Rotarian Dr. Sujata ma'am, please come. Ramya ma'am, Sridevi, Nalli ma'am. Lighting lamp koncham appadi push pannu inga. Dinesh, song play pannu. Dinesh, play please. English pannu. We should release the brochure of 7560. Just a ribbon. Okay, right. One more. Often, cool. Yes. Now we are going to release the, yeah. So we'll have photo shoot now. Next brochure release pannirama.
Release.
Now we have the release of our Southeast Asian Academy of Sleep Medicine 2025 conference brochure. This will be a 7th international conference. The first announcement brochure is going to be released by our chief guest, Dr. Shivani Swami. And the first copy is going to be issued by our organizing chairperson of this conference, CSM 2025, Dr. Tirzepatide ma'am. Yeah, Tilaga. Open. Further brochure to be given to all our faculties. Yeah, just give it 50. Okay, you can keep and photos. Thank you. Now we'll have a tea break. There is a cake cutting small ceremony is there. Our chief guest and other guests of honors will be there. This is a 10 minutes time, cake cutting and the tea break. I request everyone kindly take part in the ATM. I request everyone come to the ATM side. Thank you. Baba. very interesting, important session, keynote sessions. So the speaker will be Dr. Shivani Swami, our course director. Today is a chief guest and is a national authority in sleep medicine. So may I request the chairpersons for this session, Professor Dr. C. Chandrasekhar sir, please come to the dais, sir. Professor Dr. Magil Maran sir, please take your seat. Professor Dr. Nalini Jayanti ma'am, please take over the seat and start the program. So before that, I will give a small token of appreciation, flower bouquet to the speakers and chairpersons, because this is a special session. I request Ibrahim. Tilaka ma'am, bouquet kuduthirunga. Vapa, tak va. I request our organizing chairperson of CS conference, Dr. Telagudi ma'am, please give the flower bouquet as a token of welcome to Dr. Shivani Swami. May I request Telagudi ma'am to give the flower bouquet to our APT president, Dr. Chandrasekhar sir. Sure, what? May I request Dr. Gayatri ma'am give the memento to other guests of honor. Yeah, Dr. Nalini Jayanti ma'am, Dr. Magil Maran sir and Dr. Nalini Jayanti ma'am. Magil Maran sir. Professor Dr. Magil Maran sir.
ஸ்டார்ட் பண்ணிடலாமாப்பா? இன்ட்ரோடக்ஷன் கொடுக்குறீங்களா? உங்களுக்கு மாத்திரம் குடிச்சுக்கோங்க, பிகாஸ் பேப்பர் இங்கே வைக்கல. வெள்ள எல்லாம் சிங்கிள் மேனாக ஹேண்டில் பண்ணுறாரு, அதான் பிரச்சனை. இவர் யாரையுமே கொடுக்கறது இல்லை. ஹி டஸ் இட் ஆன் ஓன். இவரே ஓடி அந்த மெழுகுவர்த்தி வைக்கிறதுலேருந்து பண்ணிட்டு இருக்காரு. நான் பார்த்துட்டு இருக்கேன் அப்போலேருந்து. இது நான் எக்ஸ்பிளைன் பண்ணிக்கிறேன். முதல்ல எடுத்து கொடுத்துருங்க. Yes, ma'am. Good afternoon to one and all. After having heard in the morning about sleep health, everybody, we had a panel discussion, everything. After that, we are going to have right now sleep medicine scenario in India. And this is going to be presented by Dr. Shivani Swami. Her present designation is she is a senior consultant and head at Narayana Multispeciality Hospital, Jaipur. And she has done a fellowship sleep medicine along with her MD routine and fellow interventional pulmonology. And she has been certified in allergy and immunology. And major achievements are she is a secretary, Southeast Academy of Sleep Medicine. Then she is a secretary, Sleep Education and Research Society. She has authored a textbook on sleep-related breathing disorders and various publications in national and international journals. So over to you, Shivani. Without much ado, let's start the program.
So thank you again, everybody, for inviting me here. Thank you especially to Jayaraman sir. I think his energy and enthusiasm is what actually drives me back to Chennai time and time again. And I'm really looking forward to coming back in September for the 7th ICSD conference. So my topic today is sleep medicine, the Indian scenario. So this is something that, when I heard the topic, I thought, okay, this is going to be a cakewalk. But when I started doing the talk, it practically wasn't so. I think as clinicians, it's much simpler for us to, to give a talk or deliver a talk on an academic topic, because that is something that we're doing in our clinical practice every single day, day in and day out. And it's not as simple as I thought that this task would be. So I have tried to compile my thoughts. I may have missed out on some points, and I would really want this to be an interactive session at the end, and please feel free to point out whatever I have missed. So we're talking about sleep medicine, the scenario in India. When we talk about sleep, we do know that it's a naturally recurring state of altered consciousness, which we spend almost 1/3 of our lives in. However, how many times do we really stop and think about it? Not until there is something wrong with it. I think most people who are blessed with a good sleep take it for granted. And especially us, I think, as doctors, we would know the importance because we've all been through residency. We've all had sleepless nights. And that is when we actually realize how important sleep is. However, even as we get into clinical practice, we very easily, like ma'am, we've been talking about losing our gadgets at night, but I think as doctors, none of us can practically do it. We all keep our mobiles on the bedside on a ringer mode because we do not want to miss that call of emergency from the hospital, from the emergency department. And I think it's an endless cycle. So in trying to cure people, we always do compromise on our sleep. So that is something that we have not been able to get rid of. And not only us, I think even other healthcare professionals, when we look at our housekeeping staff, when we look at our security staff, or we look at our nurses, lab technicians, all of them are actually working in shifts, but we never really think about their sleep health. And that's how taken for granted we do. We talk about sleep. We talk about sleep all the time. We observe the World Sleep Day, and then I think we go back to our old ways. And same is applicable for me. I think in trying to cure other people's sleep, we are all sleep deprived. And that's how it has been. When we talk about sleep disorders, it's a huge umbrella. There is a classification. Of course, the most common, I would say, is the insomnia that Dr. Ramya was talking about. Then there is the sleep-related breathing disorders. There are central disorders of hypersomnolence, circadian rhythm disorders, parasomnias, and then sleep-related movement disorders. These are the broad classification of sleep disorders, and not just sleep apnea or insomnia. I think as pulmonologists, what we most commonly deal with is sleep disordered breathing. And of course, that again involves a lot of diseases: primary snoring, upper airway resistance syndrome, OSA, central sleep apnea, Cheyne-Stokes respiration, the overlap syndrome, nocturnal hypoventilation, and complex sleep apnea. So these are the disorders that we see and talk about when we talk about sleep-related breathing disorders. But why do we talk so much about sleep-related breathing disorders? What we need to realize that we thought until 23 that the prevalence in India alone is around 52 million. And then this paper came out as recently in 2023 from AIMS, which said that the prevalence is actually around 104 million. This is a staggering number. And we also need to realize that this is the prevalence we are talking about in the productive age group. So these are people in the age group of 20 to 60 years. We are not talking below or above that. So this is a huge number in our country alone. But where are all these patients? Why are we not seeing these patients? Are any of us seeing these number of patients? Well, I don't think so. I practice a lot of sleep, and maybe I think I see 1 or 2 patients maximum in a day who are suffering from sleep-related breathing disorder. So where are all these patients going? Are they not presenting to anybody? Well, it can't be, because it is a known fact that these are patients who actually have multiple comorbidities. Patients of sleep apnea may have multiple comorbidities and not just one. And when I talk about comorbidities, it means cardiovascular events, it means hypertension, unexplained arrhythmias, of course, diabetes, hormonal disorders, most common being hypothyroidism. And of course, the list is endless. I think today, if you talk about any disease, it does have an association with sleep apnea. Even in terms of respiratory diseases, there is an association with asthma, COPD, ILD, you name it, and the association exists It's right there, but sometimes still goes unnoticed. So these are patients, like I said, who have a high prevalence of hypertension, coronary artery disease, arrhythmias, strokes, respiratory diseases, diabetes, dyslipidemia, gastroesophageal reflux disease, anxieties, insomnia, and even depression. So varied presentations, and most times may actually be getting missed. Of course, these patients are more prone to diseases, but also patients with diseases are more prone to sleep apnea. So 63% patients of stroke may actually have sleep apnea, whether it could be prior to the diagnosis of stroke, or sometimes even the stroke per se can lead to emergence of sleep apnea. Similarly, for depression, diabetes, obesity, heart failure, resistant hypertension, coronary artery disease, and arrhythmias. So the list is endless. But also, I think there are huge cultural differences when we talk about sleep. We do not look at sleep the same way as the Western world does. We did not, at least until a few years back. I think for us, our ancestors always said, sleep early, sleep in time and wake up early. And that was the mantra that has been instilled into each and every one of us, at least I think until our generation. I'm sure the next generation does not believe in it. Maybe given the technology or the exposure, we are going the same way as the Western world is. But that's how where we are. But is it the same in the rural India? Well, there have actually been studies, to talk about the cultural differences between the rural and urban India. So there was this beautiful study done in 240 participants from both urban and rural Indias, wherein they looked at the sleep duration. And the difference, if you see, between rural and urban India was 7.4 plus minus 1.2 hours and 8.18 plus minus 1.3 hours during work days, whereas during weekends 7.13 plus 1.3 or 8.1 plus 1.35 hours. So definitely a difference between the rural and the urban setup. And even if you look at the perceived sleep quality between the urban and the rural population, there is a difference. It is not a very statistically significant one, because maybe the number of subjects is not very huge, but then there is still a difference that exists, and maybe that is what needs to be looked at. We have forever talked about sleep apnea. I think we've had multiple sessions, thanks to sir, and we all know that what we do next is a sleep study. So there are again complications in that. We do have multiple levels, and somebody who is new to sleep medicine may not really understand what to do when. We need to realize that there is a place for each one of these studies, and it is not like one is better over the other, as long as we've chosen the subject correctly. Of course, the gold standard still remains level 1 sleep study, which is also called as the polysomnography, which is a detailed sleep study which involves an in-lab, overnight, supervised sleep study, which would also include EOG, EMG, EEG, the respiratory movements, the pulse oximetry, the ECG, and the entire jing bang. So, but then, of course, I think not everybody has access to a level 1 sleep study. We do not have trained technicians. We do not have trained doctors. Of course, the equipment is a scarcity. So we have a whole lot of challenges. So then we move to a level 2. This was as good as a level 1, but it was maybe done at home or done in the hospital where a technician was not supervising this study overnight. Then there is level 3. When we talk about level 3, this is a limited sleep study wherein we are only looking at a limited number of channels, minimum 4, which must include the respiratory movements, pulse oximetry. But then there are challenges with the level 3. It does not tell you what stage of sleep apnea the patient has been in. It does not give you airflow limitations. So it has its own challenges. So who are these people who might actually do okay with the level 3? These are people who do not have any comorbidities, but seem to clinically be the tip of the iceberg for sleep apnea. So maybe they have a suspicion, a high index of suspicion for sleep apnea as per their symptoms and presentation, but they do not have any comorbidities yet. So those are people who would be okay to undergo a level 3 sleep study. A level 1 sleep study, since it still remains like as the gold standard, is for anybody who suffers from a comorbid illness and has a index of suspicion for sleep apnea. Those are people who would be ideal for a level 1 sleep study. However, we've moved to a level 2 sleep study as well. This is practically for people who do need a level 1 sleep study, but may not be able to sleep in a new environment, may not be able to sleep when somebody else is watching them. So maybe you could do a level 2 sleep study, but when you're doing a level 1 or a level 2 sleep study, please make sure that a trained person is actually looking at the raw data. Otherwise, the entire purpose of doing this study is completely lost. Then there is the level 4 sleep study, which is practically an overnight pulse oximetry. What we are doing, using it for is practically screening populations, and it has no diagnostic purpose at all. So if a subject comes to you with a level 4 sleep study, you can actually, on the basis of that data, advise him to undergo another sleep study, but definitely you cannot diagnose this patient to have sleep apnea on the basis of the data that you have at hand. But how much is the awareness? So we've talked about sleep multiple times, and then of course we've been talking about it during the day. But how does the public perceive sleep? I do not think that still people have a very high awareness of not just sleep apnea, but also sleep related issues. They do not think that any issue in sleep actually curtails them to go to a doctor, present to somebody, or go seek a consultation unless it actually starts affecting their day-to-day activities. Nobody is usually coming until they are the tip of the iceberg case. At least in India, I do not say that. And then we live with the myth that snoring is normal, that if somebody is snoring, that means he's sleeping well. So both these things do not really make a very promising picture for sleep disorders in India. But that's how where it is. That's where we think that we need to increase awareness, but not just public awareness. I think a lot of the RMPs, the physicians working in an absolute peripheral center, are also aware. And the major reason for this unawareness amongst physicians or medicos is the lack of sleep apnea or sleep related breathing disorders or sleep disorders being mentioned in our curriculum. I do not think when I did my MBBS, I ever thought or read about sleep related disorders at all. It is just not part of the medical curriculum at an undergraduate level. So that's where we are. How do you expect somebody to see something that their mind does not know? They do not know. And even when I did my MD, what I think Fishman had just one unit of sleep related breathing disorders, and that was my only exposure to sleep related breathing disorder, that it might actually appear in the exam as maybe a short note at some point, and that was all. Maybe a few sleep studies that we saw while we were doing our PG, and that's all the importance we ever gave to sleep. But now, today, here I stand talking day in and day out about sleep. So that is actually, I feel, a long way that we have come, but there is still a very, very long road that we need to cover ahead. And every individual trained in medicine, and not, I would just say, ki allopathy, I think any stream of medicine, any stream to do with health, I think has to be aware that sleep disorders exist. And those things actually come into picture wherein we would then be able to maybe improve our diagnostic facilities, because the demand actually would meet the supply. So, I mean, there's no point when there is no demand, there is no awareness. Why would anybody want to invest into sleep facilities? And that remains a major challenge. The sleep facilities that exist today struggle because people are not aware. They do not want to spend out of their pockets. And that is the general perception. I am sure that all of us who practice sleep do come across patients wherein probably a specialist has seen them and told them, okay, maybe go see a sleep specialist, maybe go get a sleep study done. They've never been really convincing. They have never really pushed the patient to go get a sleep study done. It would change your life. This is practically the cause of your problems. and you must go ahead. I think I see very, very few patients who come with that conviction that the doctor said you must get it done, and hence I'm here. That is still not happening, and that mindset actually has to change. That does need a change. And even though the JNC 7 actually talks about hypertension being one of the causes for sleep apnea being one of the main causes for resistant hypertension, it clearly states that anybody who is a case of resistant hypertension does need to undergo screening for sleep apnea. But how many cardiologists are actually referring the patient to you for resistant hypertension to screen these patients for sleep apnea? I think hardly any. But this is not a story that ends at cardiologists. How many endocrinologists are sending us patients? How many neurologists are sending us patients? I think between the sleep fraternity, anybody who takes keen interest in sleep medicine are the only people who are practicing sleep medicine. And that mindset is what we need to change and increase awareness to a point that it is being talked about, just like we talk about diabetes. A few years back, nobody talked about insulin. People didn't want to take insulin. And look at where insulin is today. So I think that is the kind of drive that we need to talk about sleep medicine in India. When we talk about treatment and management, of course, multiple challenges here as well. The options, like we said, the gold standard still remains PAP therapy. Cost is an issue. Compliance is an even bigger issue. We all know that the compliance with PAP therapy is not really promising. So are we actually offering these patients a very promising therapy? No, they would probably use it for 6 months, 1 year, and then they would, for some reason or the other, just stop using. You just lose them to follow up. Of course, there are things that have been done to improve that, like maybe the cloud monitoring apps that are available, that somebody keeps a tab about how much the patient is using it, whether they're using it, whether they're facing any issues. But as long as you keep a tab, great. If we are not even using that, then of course, it's a challenge. We do also realize that there is nothing that covers these patients for PAP therapy. So that is always going to be a challenge in terms of cost. But do we talk about other modalities? Do we really enough or cross-refer enough to our colleagues, maybe in the ENT or maybe dental? I saw this wonderful presentation. We were talking about the pediatric dentistry, and actually in kids who have sleep apnea, an early intervention with the pediatric dentist can actually prevent them from developing sleep apnea in adulthood. So that's how important, that small intervention in childhood can actually change how they behave or how they turn out as adults in terms of their health. So these are small things that we never actually pay attention to. The pediatricians don't think of sleep apnea and PIDS. All they think about is maybe adenoids at times, max tonsils, and that's about it. Nobody's talking about sleep apnea. Nobody's looking at the shape of their jaw until the parents actually take them to a pediatric dentist. Nobody's thinking about it. So these are things that we need to collectively talk about, change. This is not a pulmonologist domain. This is not a neurologist domain. This is not a dental domain. This is nobody's domain. This has to be a multidisciplinary approach. Just like how in cancer, the difficult to treat cases go to MDTs. I think every institute today has a MDT for cancer treatment. Why not sleep? We have to have the same approach. It has to be a collective effort because it is not about the pulmonologist. It is not about the ENT surgeon. All this is about is the patient. We all should collectively think about how and what can actually help the patient. The ENT surgeries are a wonderful tool if the patient selection is correct. So we all have to be on the same page. We have to work as a team, and only then the sleep medicine stream can actually take off. But do we leave out the other modalities out of this? Not really. So there are definitely studies that show that even in insomnia, Ayurveda has very good results. So I think Dr. Ramya would agree that along with CBT, patients who were subjected to Shirodhara did actually have good outcomes. So these are also, allied sciences also do play a major role. They have concepts which probably may seem historical to us, but are very scientific when we look at them in terms of theory. And a lot of those concepts are the ones that the West is actually now going back to. So of course, Ayurveda has a role. When you talk about sleep apnea patients, the myofascial training has a role. So all of these modalities do have their own role under the umbrella. And it is not that, I am the only one who is going to treat sleep. No, we cannot work with that approach any longer. And we need to realize that all of this would need an effort to train more individuals in sleep, and not just doctors, also technicians. What does a good doctor do when he doesn't have access to a trained technician who can deliver a good quality sleep? If the raw data is not good enough, what does he interpret? So all those are things that we must need. I think Jayaraman sir's initiative in training doctors is excellent when it comes to training doctors, because there are very, very few structured programs in India currently wherein they do train in sleep. So that's obviously it's online plus on-site training, and that is just the perfect model to do it. Because we need to realize that the main challenge that these patients actually face is the high cost of diagnosis, because definitely sleep study is not cheap. It goes from somewhere, a level 1 goes from somewhere between 10,000 to 25, 30,000, depending on which city you are in. And that's not cheap if somebody is having to pay out of his own pocket, because none of the insurance schemes cover sleep. None. I think very recently, one company has launched one specific plan wherein they would cover the sleep disorders, but that's about it. That's where the coverage starts and ends. Just one single plan. And nobody else is covering it. Of course, the other government schemes that we know of, they talk about doing a sleep study, they cover it, but they do a sleep study, at least from where I come, 700 rupees, a level 1. Nobody can do it. My technician charges much more. I may not be able to do a study when I have to pay the technician out of the pocket. So that is where we are at in terms of a lot of loopholes. We've talked about the multidisciplinary care. We have to have integrated patient management, and definitely to lose weight, manage their lifestyle, also include a nutritionist, and sometimes for the myofascial training, even the physiotherapist. So all these things are that would make a difference. Talking about the future prospects and recommendations, of course, I think what we need is a more structured planning at a national level and not just our individual level. The planning actually has come from an individual and has to go to the institute and eventually has to culminate into the policy making of the nation, which is completely lacking. So that is where we are at. Of course, role of technology, very beautifully discussed already. So I would just like to add that, of course, there are cons to technology like we've discussed, but then there are also pros. So the apps that are there in the watches that, we talk about, the Samsung had it earlier. Now, recently, the Apple app has also been approved by US FDA for the for reading sleep apnea. It does give you an AHI. I think these are excellent tools, because if nothing, this is going to set people talking about sleep apnea. You might actually get more patients who present to you that my watch data is actually showing that I have sleep apnea, that my AHI is high. Do I need to do something? So I think for that purpose, it's amazing. And also for other people who have sleep work disorders, for them to keep a tab of their sleep cycle, how much they've slept. I think, again, that's an excellent tool. It practically works as actigraphy for them. So I think these are where technology will actually come handy. And with that, if there are any questions, any discussion, any points that I have missed, I'll be happy to take suggestions.
Thank you, ma'am, for the wonderful speech. I have one or two clarifications. People will have OSA with associated with diabetes, hypertension, CAD. Whether we can consider as a comorbid or due to a complication of OSA because it's a pro-inflammatory state. What do you think?
So I think this is a chicken and egg story, sir, about who came first. But definitely there is enough evidence to show that people who have sleep apnea, which goes undiagnosed, they are more prone to have diabetes, like you said, as a maybe as a result of the sleep apnea, the inflammatory stage that is going on of the recurrent hypoxemia. They're also more prone to cardiac events. And at the same time, the coexistence of sleep apnea when these diseases exist, the control is much poor if the sleep apnea is not treated. So this is like a vicious cycle, which never gets broken until we treat the sleep apnea.
One more thing, madam. People with OSA have met with road traffic accident mostly between afternoon 1 to 4. Why that specific timing? Is there anything? They are not coming with the accident in the morning time. Is there anything related to timing?
So road traffic accidents actually remain a more complex problem, sir. So they are more prone to accidents at 1 a.m. to 4 a.m. also,
That's
and
deep sleep deprivation.
and 1 p.m. to 4 p.m., which is usually the post lunch slumber that they fall into. So it is also a known fact that people who have shift work disorders or sleep apnea, especially sleep apnea, a lot of industries in the West do actually give them napping opportunities. So patients who have sleep apnea are actually given longer napping opportunities compared to their counters, to actually counteract the industrial hazards or industrial accidents which may occur because of the sleepiness that they have at that hour.
Thank you.
Ma'am, I have one question. What about the use of melatonin in, because they are talking about melatonin usage in sleep hygiene to look for the quality of life and all that, sleep life.
So melatonin, ma'am, has a use in jet lag, of course, and sleep phase disorders, sleep shift work disorders, wherein people who are now they finish their night sleep, they want to go to sleep, so 2 hours at least before bed, they should start. They should take melatonin. That would actually just to set their cycle in rhythm, their hormonal cycle to sleep in rhythm. So that those are the specific indications for melatonin.
Are you seeing of late, now we were talking about stop bank score and all. See, we teach our students and all. So gender discrimination is there. Usually we are talking about a male gender in that particular G. So now we are seeing even in females, in the morning, right from the morning, we were talking about females, they are not complaining and all that they were telling. So have you seen in your practice that gender discrimination is there and it is increasing in women?
So there is actually a lovely study, ma'am, about that. That when we talk about sleep apnea in women, there is a hypothesis that says that women actually do not present to OPD with their health concerns. Women always keep their own health at the back burner until it is something that is being extremely distressing for them. That's first. And secondly, women also very often present with different symptoms. The symptoms could be insomnia, it could be depression, it could be unexplained body aches and pains, and such things. So they may not really have the usual presentation, because of which also it might actually be getting mixed. However, studies have also shown that the hormonal benefit that the woman has does have a protective effect when it comes to estrogen. It does have a protective effect, and hence postmenopausal women have a similar incidence of sleep apnea. And like ma'am was discussing, women actually have varied hormonal cycles. So it's not only about pregnancy, menopause, menarche. It's not only about those things, but also all through their menstrual cycle of those 28 days, they have such varied hormonal variations that physiologically their sleep, even during that cycle, is extremely varied and different. So all those things play a lot of role.
Madam, is there any correlation between Mallampati scale and the severity of polysomnogram AHS in this?
So, ma'am, sir, initially when we started off, of course, Mallampati score still remains an integral part, a backbone of when you're examining a patient of sleep apnea. So that definitely has a very close correlation, but it is not, and similarly is BMI. But now increasingly we are seeing that those are not the only correlations. We cannot just sign off somebody because he has a good Mallampati score, or maybe because he's not obese, to not have sleep apnea. So definitely has a stronger correlation, but it is not the end all and be all.
Referrally is a very important PSP specialist. And to what percentage of cases you rely on the clinical aspect, and
how do you go to the sleep studies? Is it a must for evaluation through clinical evaluation versus the investigatory part? How do you go about as a specialist?
So, sir, I feel that very often in our practice, we actually only get tip of the iceberg cases, those who are very high index. So, I think I at least hardly see patients who are low index of suspicion and still presenting you for sleep issues. So, of course, Stop Bang is an excellent module to screen these patients whether they do need a sleep study. If they have any comorbidities, then you subject them to a level 1 sleep study. If they do not have any comorbidities, the less cost effective cousin, which is the level 3, would be a good option. But yes, I mean, if they do present to the OPD, I would like to screen them.
Just to consultants among the medical specialists, the awareness is a must, and proper referral has to be done. Some of my friends work in US. They have a sleep study, sleep labs, and it's a common sequelae. They give a lot of importance. Identify and just refer it. You will take care of it. That's the motto.
Yeah, I think for us, what is more common, sir, that we are taking the ICU round and we see this patient has sleep apnea, this patient has sleep apnea, and nobody has actually referred that patient to you. Or somebody who presents in the emergency room with a acute on chronic type 2 respiratory failure, but nobody has ever worked him for sleep apnea. I think that's the more common scenario in our country, if you would agree.
Yes, I work in a obesity unit. So OSA is the first one to get addressed once a patient uses a week. But that's a different scenario. But your is master.
So, madam, this is regarding the road accident and sleep deprivation. I think everybody knows Professor Matthew Walker, the famous neurophysiology. He has written in his book that if a person is sleeping only 6 hours or less, the chance of making an accident is 3 times. And if sleeping only 4 hours, it is 11.5 times the chance of making an accident. Just an addition to the, so that's the importance of having good sleep.
So one more last question from one of our senior colleagues. He is online. Do we have any other marker other than snoring for public screening? He's a senior consultant pulmonologist.
So I think in general, when we talk about, it's not only snoring, it also has to be about witnessed apneas, disturbed nighttime sleep, sleep inertia, morning headaches, uncontrolled hypertension, uncontrolled diabetes. I think all of these actually have to be taken into account.
Yeah. I would thank Dr. Shivani for enlightening us on the scenario of India, where we have to enlighten even our own specialists, right, and colleagues, along with increasing our infrastructure by training a lot of good technicians for proper sleep study information. So thank you once again for the excellent talk. I would thank the organizers for inviting me, Professor Chandrasekhar and Dr. Nali Jayanti for this meeting. Thank you.
So I think if there are no more questions, if you have any more questions, you can always discuss with her at the lunch hour. Thank you.
Thank you very much, madam. We had a wonderful keynote session by Dr. Shivani Swami. I request Dr. Shivani Swami to give the certificate memento to our chairpersons, Professor Dr. Chandrasekhar sir, Dr. Magil Maran sir, Dr. Nalini Jayanti ma'am. Thank you. Over to Sridevi for the announcement for the quiz program for the PGs. Sridevi.
I hope you all are aware of the quiz which is going to happen in the pre-lunch session. I think all the postgraduates who have given the names from the lucky lot, we have selected few of them. So just can you raise up like when I read out your name? Dr. Sanam Vandana. Dr. Sanam Vandana is here? Yes. Dr. Dileepan. Dr. Dileepan. And Dr. Amir Mustaq. Yes, you belong to team B. Dr. Kripa Jaiswal.
Mike Matra.
Dr. Isha Gohini. Yeah, you both belong to team C. Team D, Dr. Karthikeyan. Dr. Nivedita. Yeah, you both belong to team D. Okay, so please remember your teams. Team A, Sanam Vandana, Dr. Dileepan. Team B, Dr. Goli Sahiti, Dr. Amir Mustaq. Team C, Dr. Kripa Jaiswal, Dr. Isha Gohini. And team D is Dr. Karthikeyan and Dr. Nivedita. Okay, please be ready after the next session. I think we will have the quiz, okay, before the lunch.
Thank you, Sridhari. May I request our chief guest, Dr. Shivani Swami, please pick up some slot here for the lucky draw gift. Lucky draw gift, Sridhari. Name, just read the name. Dr. A. Gauri Shankar. Lucky draw gift for Dr. A. Gauri Shankar. Yeah, please come, sir. Gauri Shankar. Lucky draw gift. Yeah. Right. Next one. So next step. Next step. Yeah, Dr. Vasanta Rao. Dr. Vasanta Rao, ma'am. Lucky draw gift to Dr. Vasanta Rao. Welcome. Give that old one. Old one. Put it here. Oh, this is good. This is a lucky draw gift. Thank you, ma'am. Brian. Yeah. We finish everything. You guys post lunch. Dr. Sridhar. Dr. Sridhar. Sridhar, lucky draw gift. Come on, welcome. என்ன நீ எழுதவே இல்லையா? நான் போடவே இல்லையே. அப்படியா? மிஸ் பண்ணிட்டேமே. கொடு. Please, two more. Dr. Sashia Banu. Dr. Sashia Banu. Welcome, madam. Yeah, last lucky draw gift. Dr. Ansia. Dr. Ansia, ma'am? Huh? ENTPG? Ansia, ma'am, yeah. Last time also she got the prize. Last girl sleep day. ENT or PG? Our ENTPGs. Yeah, please.
You give this one. Come, sir. Please. You're the lucky one.
Next program, then we'll lunch. We'll move to the next session. There is before the quiz program, we have an important session. Restless leg syndrome. Ma'am, guide. Yeah. No, please.
So for the next session, I invite the chairpersons for this session to please come to the dais. Dr. Sabarinath Ravichandar, Dr. Sindura, and Dr. Deepika, please. And I invite Dr. Srinivas to give his talk. He'll be speaking to us on restless leg syndrome. And I invite the chairpersons to introduce the speaker and the topics.
Good afternoon to all. I think this is going to be an interesting session for also the pulmonologists because and for all the audience, because we're going to go towards a very common disease. Sometimes I even think that I am having this problem, madam, restless leg syndrome, because most of the gents when they are sitting, they used to do like this. Okay, so I want to ask all those questions to the speaker. So I think sir is an experienced speaker, Dr. Srinivas sir. And sir is a consultant neurologist and has a special interest in movement disorders and vertigo at MGM Healthcare Hospital Chennai and Arunai Neuro Center Chennai. So let's talk about this restless leg syndrome, also called as Willy Ekbom syndrome. Correct, sir?
Yes, Willy Ekbom.
Yes. Thank you, sir. Start.
Thank you. Thank you for that nice introduction. So my topic today is restless leg syndrome. So as rightly mentioned, it is also known as Willy Ekbom disease. There's always a question, why are we talking about this at a sleep summit? So is it a sleep disorder? Is it a movement disorder? I'm a movement disorder, so I like to think of it as a movement disorder. But when we look at it, basically it's a movement disorder which can lead to a sleep disorder. Yeah. So it is basically a movement disorder which can lead to a sleep disorder. So it's at the borderline between sleep and movement disorders, if I can say it like that. So it's a very chronic disease. It's a very common disease. It's an extremely underdiagnosed and very. Many a time it leads to there's a lot of delayed diagnosis related to this disease. And the common problem is there's an irresistible urge to move the legs. That is the one symptom that we know. Okay, this is possibly a restless leg syndrome. We don't have any data from India, unfortunately, about the epidemiology. There's been a lot of 3 million patients reported every year in the USA. In India, we tend to underdiagnose this disease, and we do not have any large-scale studies which can tell us how prevalent the disease is. But looking at how many patients I end up seeing every week, I'm pretty sure it is at least more than 20%. The diagnosis usually occurs very late, after the third decade. It can occur at any age. It can occur in the children. It can occur up to an age of 90. And there is a history that there can be a familial restless leg syndrome, which can lead to an earlier diagnosis in many a time. Women tend to be more affected than men, and Caucasians are more affected than us, although it is quite common in Indians as well. The risk increases during pregnancy, especially in the third trimester, and the prevalence is also much more common in patients who have end-stage renal disease and CKD. So when you're trying to differentiate restless leg, we try to say primary and secondary. Any disease we try to say primary and secondary. So primary is what we call idiopathic. We don't have the etiology. Secondary is if there's any other underlying cause which may be causing very similar symptoms. Also, based on the phenomenology, we also call them chronic, persistent, or intermittent. So chronic persistent if it is occurring more than 3 days a week. So if it's almost every day it's persistent for at least 1 year, then we call it chronic persistent. It occurs less than 2 events per week, but we need to have at least 5 events, then we call it intermittent. So secondly, a lot of underlying causes which can lead to a restless leg syndrome. It's a huge list. The most common we just need to know at the top, the iron deficiency, which we all know about, the end-stage renal disease, and diabetes mellitus. All three are extremely common in our country, and all three can lead to corruption. And often overlooked on the risk side. These things we do not take into account many a time. We do not go through the drug list. If somebody is having these symptoms, this is something we need to always look at, whether they are any dopamine blockers. I know we have a few psychiatrists in the crowd. Unfortunately, I will have to blame them a bit, because many a time, any prescription, most of their prescriptions can lead to worsening of this syndrome. You can see that SSRIs, SNRIs, TCS, and neuroleptics, dopamine blockers, almost all the drugs used in psychiatry will end up worsening this syndrome. So that needs to be looked into as well. And this is one of my personal interests, that is Parkinson's disease. We know that restless leg syndrome has been reported to be a prodromal symptom in Parkinson's disease. It can occur many years before the motor symptoms even occur. It is much less common in Asians, although it's much more common in Europeans. and it is now being considered a biomarker for subclinical PD. There's a lot of talk about disease-modifying therapy in Parkinson's disease. So if somebody has Restless leg syndrome, maybe in their 30s or 40s, might be worth looking up if they might have any other signs of Parkinson's, so that we can start intervention early on. So when you talk about the pathophysiology, why does restless leg syndrome occur? There's a lot of theories going on, but the most commonly accepted is there's a dopamine dysfunction and iron depletion in the brain, especially in the substantia nigra and thalamus. The substantia nigra is where the pathophysiology for Parkinson's occur as well. That's probably why both of them are so closely linked together. So there has been a suggestion that it is autosomal dominantly inherited. However, no specific genes have been found. In pregnancy, we know that there is vitamin D deficiency, there is calcium, low calcium, there is low iron and ferritin. So all of these can cause worsening of the disease. And end-stage renal failure, we know there's functional iron deficiency. The iron may be normal in the blood, but it's not being functionally utilized. And there can be subclinical peripheral neuropathy, again, which can lead to very similar symptoms. The symptoms, again, it is a broad spectrum. There is not one symptom. The only one symptom which I can say consistently the patient will have is that it gets better on walking. That is the one symptom which you can get from the patient. Okay, I have a symptom, I have pain in the legs. Many a time these are misdiagnosed as peripheral neuropathy. Patient is put on, in our country, everybody goes on to gabapentin and pregabalin. Doesn't matter what symptom they actually have, which is actually good in a way, because pregabalin and gabapentin can improve restless leg. The problem is many a time people tend to put it in combinations, pregabalin with nortriptyline and gabapentin with nortriptyline. Unfortunately, nortriptyline can worsen your symptom. So the symptoms here can be very similar to any sort of peripheral neuropathy. They have paresthesias rather than pain. They'll have this crawling, creeping, uncomfortable sensation. So that is the one thing which you need to look at. Do they have an uncomfortable sensation in the legs? It's very difficult to differentiate because it can look very similar to any peripheral neuropathy pain, and the severities can vary from mild to extremely severe that they just cannot lie down. So the three histories I like to check with them is, does it occur more in the evenings? Does it occur when you lie down in bed? Are you able to sleep, or does it disrupt your sleep? So if you're not able to sleep, what do you do? Many a time they'll say, okay, I have this symptom, I have a pain in the legs, but I have to get up and walk, it gets a little bit better. So that is a good clinching point. This might be restless leg rather than actual peripheral neuropathy. And of course, it occurs within 15 minutes of lying down. Another close differentiation we need to keep in mind is nocturnal cramps, very common in patients who have renal failure, very common in pregnancy, very common in diabetes. So what the differentiating factor is that nocturnal cramps usually occur many hours after sleeping. They usually wake up from sleep with the cramps, whereas in restless leg, it occurs initially on lying down. They are not able to fall asleep. If you can able to make this differentiation, it is actually easier to treat them. And of course, as I said, the severities can be it can be mild and it can go up to extremely severe. There is also something called restless leg limb syndrome, where the leg might not be involved, only an arm might be involved. They say occur even without the leg being involved. And the patients they give the history that I'm just out of bed all day, I'm walking around all night. So because I'm not able to sleep, because I'm feeling so uncomfortable. Sometimes it gets so bad that they can't even sit still, not even just lying down. Even sitting still in the evening is very hard for them. And they can also have something called periodic limb movements of sleep, which occurs if their severity is very bad. And clinical examination, most of the time, is normal. They can sometimes find small movements in the legs. They can have a bit of dorsiflexion, few seconds. They can occur very slowly, that is once every 30 to 40 seconds. So you need to keep watching them for at least a minute to see if they're having any abnormal movements. It can occur during all stages of sleep. And when you're examining, always look for secondary causes. As a neurologist, I want to see if there is any peripheral neuropathy, any signs of Parkinson, if there are signs of radiculopathy. A quick sensory examination, quick motor examination, and deep tendon reflexes is usually good enough. There has been a criteria which has been put up. This came out in 2014. As you can see from the file, it's very simple. It's a purely clinical diagnosis. There is no test to confirm restless leg syndrome. There are no blood tests. There are no investigations which can tell you that there is restless leg. It comes down to your clinical acumen, whether you can take in the history correctly. So do they have an urge to move? And does it occur during periods of rest? Does it improve on woman? It may not completely disappear. It may be a partial improvement as well. And it occurs more in the evening, or it can be only in the evening. So if you have all these four, yes, then most likely you are dealing with restless leg syndrome. And the occurrence of course, we'll have to rule out any secondary cause before diagnosing it as a primary RLS. So when you're talking about the symptoms, as you said, the abnormal restlessness, and the discomfort. These are the two things we need to keep in mind. The restlessness, the other things we need to keep in mind is that you can have akathisia. We talked about neuroleptics worsening RLS. They can also lead to akathisia. So differentiating them is very hard. However, the urge to move and the circadian rhythm is very different. So akathisia can occur even in the morning, whereas RLS much more likely to occur in the evenings and the nights. Orthostatic tremor, that is again a restlessness. They'll have a discomfort in the legs. They'll feel unsteady. They get better on walking. So again, the discomfort is kind of different. So if you have the pain and the paresthesia, much more likely to be an RLS compared to the orthostatic tremor. I mean, as I was talking about the discomfort in the night, nocturnal leg cramps, sudden onset, they're short duration. They can occur. Usually, they awaken the patient from sleep. That's a good clue. Whereas RLS, they have difficulty falling asleep. You can have arthritis. The joint pain can occur usually early morning. And myelopathy and radiculopathy can have dysesthesias. They can have spasmodic cramps in the legs as well. Again, usually there will be a lot of deficits on testing. And of course, polyneuropathy is a very, very close differential. The only clinical clue is that there will be deficits on examination. So, and the other symptoms you talk about, unusual motor outcomes, they can have painful leg moving toes, which can occur without any other underlying cause. It's just the muscle pain or fatigue can occur. And of course, claudication can occur, but the difference is that it feels the claudication worsens on walking, whereas the restless leg syndrome actually improves on walking. And nocturnal hypermotor, we always talk about jerks. Patients have hypnic jerks, which are very common. They are physiological. They do not need to be, nothing needs to be done for them. And periodic limb movements of sleep, of course, occurs when there is very severe RLS. How do we rule out secondary causes? Always in any patient, suggesting please look at iron studies. So when you ask about iron studies, it's not enough if you just do serum, CBC or a hemoglobin level. Please do ask for a ferritin level. Many times it's missed, and also look at the total iron binding capacity and the saturation. Also rule out renal failure, rule out diabetes, look at magnesium levels, thyroid and a folate, of course. And there might be worth doing a no conduction study to rule out subclinical peripheral neuropathy, especially if they have any underlying etiologies such as diabetes and a renal failure. Polysomnography can look for efficient sound, and of course, looking at the frequency of the leg movements and if there's associated periodic leg movements of sleep. Iron studies may be reported if there is worsening after the initial improvement. How do we manage them? Of course, initially, non-pharmacologically, try to take away drugs. That's the first thing we need to do. Try to take away the triggers from caffeine and tricycling and all their antipsychotics and the antidepressants. Most often need to be taken away. Iron supplement can be started, especially if the ferritin is less than 50. Regular exercise in the evening, massage before sleep, heat therapy, and device therapy where they can provide stimulation, subcutaneous stimulation at night can be very beneficial. When we come about pharmacological, the drug of choice remains dopamine agonist. However, there's a lot of problems with dopamine agonists. They can have side effects, especially with weight gain and impulse control disorders. Roticotin as a transdermal patch is very good because it can reduce the risk of augmentation, which I will talk about later. And pramipexole has been shown in studies to be more efficacious than ropinirole. Commonly used drugs, these are safer drugs for us to use because most of us would have had much more experience in using them. So you can ask gabapentin and pregabalin, especially if the patient has associated insomnia, anxiety, and if they're complaining of pain. And they are usually effective up to 5 years from the initiation of therapy. You can see, as you can see, you can go to very high doses. You can go to up to 900 to 2,400 milligram for gabapentin and pregabalin up to 450 milligram. Many a time, we do not go high, so high because the patient will start complaining of side effects. In pregnancy, it resolves after delivery, and we try to keep the management non-pharmacological as much as we can. Always look at iron levels. Try to improve your iron levels with the ferritin as well. And the one drug which can be used in pregnancy is carbidopa-levodopa, which we usually do not use in other stages because it is extremely safe in pregnancy. And low-dose clonazepam can also be suggested. And when you talk about the guidelines for management, we look at it is a personalized choice what you want to do. We always look at what the underlying etiology is. Is there any associated comorbidities before deciding what drug you would want to use? Somebody has psychiatric illness, somebody has impulse control behavior disorders, dopamine agonist should not be used. Somebody is obese, they might worsen with the weight gain. Please do not use dopamine agonist disorders. And of course, if they have severe pain, of course, please go with an alpha-2 delta ligans. We look at the efficacy. Suicidal ideation, as you can see, can be increased with pregabalin, whereas dizziness is much more common with pregabalin, whereas pramipexole much more likely to result in headaches, and nausea has been reported with dopamine agonists as well. So iron supplementation is one concept which we have to keep in mind, which we do not do most of the times. We look at the saturation levels as well as your ferritin levels before deciding to start iron therapy. Saturation is good, and if the ferritin levels are high enough, there's no role for iron supplementation. Most of the time, oral iron is good enough. 325 milligrams is pretty much good, especially when combined with vitamin C. It can be given as in once daily, preferably at night. We give a dose for 12 weeks and then stop and see if the symptoms recur. If the symptoms recur, we can reassess. And if the levels are again low, go back to oral, or else if there's no effect, we can consider IV treatment. IV treatment, as I said, moderate to severe, and if the oral treatment is failed, we can consider IV. Ferrous carboxymaltose remains the first choice. And after iron treatment, it's usually given 2 doses, 5 to 7 weeks apart. We reassess after 12 weeks and see if the symptoms have improved or if the iron levels have improved. If they're not improved, we may consider repeating the dose as well. In pediatric patients, we have a lower threshold. There, the cutoff was 75 micrograms of ferritin. Here, even 50 micrograms of ferritin, it might be worth giving supplementation. And of course, there's one concept you need to keep in mind called augmentation. This is much more common when we are using dopamine agonists. Over time, suddenly the patient can have worsening. They might have been doing pretty well with medication, and suddenly they might have sudden worsening of the symptoms. And the symptoms start earlier in the day. So they start in the afternoon, more other parts of the body start to get involved, and the intensity starts getting worse. So when we notice this, please again go back to the drug list, see what the dose is happening, look at the age, and of course, if they've been being treated for more than 2 to 3 years, there's much more likely that they're developing augmentation. And with augmentation, please eliminate all exacerbating factors. Try to change their lifestyle, increase in exercise, go for massages in the evening. And if there are any triggers, please do that. And look at the iron levels again. After treating all this, if there is a mild to more, if mild, you can consider just direct switch off the drug to alpha-2 delta ligands, or you can use a roticotin or long-acting dopamine agonist, which has much lesser risk. If there is severe augmentation, it is very hard to switch immediately because there can be severe worsening once you stop the drug. So you can do something called a cross titration, where you gradually reduce the dopamine agonist and increase the alpha-2 delta ligands. Or there is one concept where you completely stop all drugs, give 10 days, and then see how the symptom severity is, and slowly reintroduce a medication. But this is very difficult to do in our scenario because this will require a close monitoring and preferably has to be done in inpatient setting, but no patient is going to be willing to do that. Everybody wants instant results, so that's a possibility which I usually do not encourage in my patients. Of course, if there's augmentation, we can switch to long-acting preparations. There is pramipexole and extended release as well as roticotin, which can be used. Opioids can be used if there is very severe symptoms and augmentation, and we could not use the alpha-2 delta ligands. However, this is something which comes with its own set of complications, especially with regard to sedation and addiction. So take-home message, there is a very strong clinical suspicion necessary to make the diagnosis. There are no tests, there are no investigations which can tell you the diagnosis. Always rule out secondary causes, and the treatment choice needs to be individualized. Keep a watch for augmentation. And of course, in every patient, please follow up for signs of Parkinson's disease. Thank you.
Hello. Yeah. Sir, it was excellent revision of the topic, restless leg syndrome, sir, no doubt. But few questions we want to discuss.
Yeah, please.
Especially the pediatric population, sir. Pediatric population, what will be their complaint? Adults, okay, they will say that I'm having some crawling sensation, so I'm feeding to urge, and I'm doing the repetitive movements for that, and once I wake up, I'm fine. But when it comes to the pediatrics, many times children won't know how to complain. They won't know what is it, but they will be very irritated and they will be crying. So in those cases, how you diagnose restless leg syndrome? Is there any criteria or is there any examination test?
So there's no examination test, or unfortunately, we don't have a criteria either. But one thing we need to keep in mind is, if you suspect, it might be worth giving a trial of treatment. Especially in children, we suggest ferritin replacement initially, of course. All the other medications are slightly, because they have their side effects, suggestion would be to go over iron supplementation and see if they get better. And The clinical suspicion usually arises if the child is not sleeping at night or complaining of leg pain in the night every day. So every day leg pain in the night, okay, we need to give, if there is nothing else which is explaining why the leg pain, then yes, we need to keep in mind, okay, could this be a restless leg syndrome? Please rule out anemia. Because in children, that remains the first etiology for this.
Okay, sir. Yes, many males are also, even including me, sometimes I sit and do like this. Do you label me as restless leg syndrome?
Are you able to control it on your own, sir?
I don't know, sir. Somebody saying, sir, you're shaking the leg. Then after that, oh, sorry. Like that I'm doing. I'm not even aware. So I just want to mean that whether it is a restless or what, or the criteria should be a praying or crawling. Then I'm urging and moving. Then it is restless leg syndrome. Or simply I'm moving also, it is a restless leg syndrome.
It has to be an urge to move, sir. If you're not able to control it, that urge to move, that you get relief only after moving, then it becomes an RLS. If you're just having you're just moving, there's something what we call stereotypies or behavior
style.
So that's completely fine, sir.
Yes, sir. Ma'am.
Thank you, sir, for that enlightening talk. Just a small question. Would you suggest any lifestyle modifications before starting medical management?
Yeah,
and when is the threshold to start someone on medical management?
Depends on the severity of the symptom, ma'am. So because many times the two things which people come in with. One is a refractory leg pain. So they'll come in with refractory leg pain. They'll be like, oh, I've tried multiple medicines. People have put me on medicines for neuropathy. Nothing is helping me. Then, of course, then a suspicion is coming. Okay, is this restless leg that they've been treated with the wrong medication? As I said, tricyclic antidepressants are chronically used for anybody for. So you see a gabapentin NT and a pregabalin NT in every prescription for neuropathy. Unfortunately, that is something which is not thought about. So we'll have to go back to them. And if they are saying, okay, I've been having pain, but nothing is helping me, I'll have to go back to the drugs. Then I'll have to check if this could be a restless leg, change their medication around and see if they get better. Another thing is if they sleep, if they're not able to fall asleep. So many times there's like, okay, I'm having insomnia, I'm just restless. What happens is this is treated as anxiety. Again, same problem comes down. Look at the drugs. So we try to take away the offending drug and see if it gets better. If it does not get better just by removing the drug, then we have to think about starting them on medication. That is how we usually go. And when it comes to lifestyle, of course, we have good sleep hygiene. Anytime, good sleep hygiene is something we always talk about. Avoid caffeine in the evenings. Try to take away, try to exercise in the evenings. Maybe give a massage before going to bed. So that's or give a hot water bath or a hot water rub before going to bed. That might be something which might be useful as well.
Thank you, sir. Thank you.
Yes, sir.
So you can use mic.
So the prochlorperazine and promethazine, they tend to cause extrapyramidal symptoms as a rare possibilities. But then as for the treatment, it is recommended, diphenhydramine is recommended. Is it a partially suppressing agonist kind of a thing, or as you have rightly pointed here, that is also one of the etiology you have said that. So where do you explain this to, sir? Yes. I have two more doubts.
Yes, sure. So in talking about chlorpromazine, they are histamine and antihistaminics most of the time. So they can worsen the symptoms. They do affect the extrapyramidal symptom in a way. Why we use we use diphenhydramine, as you said, injected uses for acute reactions. They would not use it for chronic drug-induced reactions. For acute drug-induced extrapyramidal syndromes, we use it because we say that because of the anticholinergic effect. Anticholinergic effect is what we are looking for, not the antihistamic effect. So anticholinergic, especially in an acute reaction, can reverse it immediately. So that is what we look for. But for chronics, we do not use anticholinergics because it can worsen it as well.
Sir?
Yes, sir. Yeah. Yes, sir. Yes. Akathisia, the differentiation is usually present throughout the day. So akathisia is usually present throughout the day. They will have the same restlessness. The good clue is that this occurs much more likely in the evening when they are going to bed or when they're sitting still. Akathisia occurs during sitting still as well, but usually occurs all through the day. There's no diurnal variation. That is the one clue we can have. Of course, many a time what we end up doing is therapeutic trials. We try switching the drug, see if akathisia improves. Doesn't improve, then we think about, okay, this is restless leg. It is because we do not have a test to diagnose. It has to come down to your clinical acumen many a time, sir.
Yes, sir. Can we keep that as last question, sir? Then we can discuss to sir as alone. Sir, concluding remarks. Thank you so much, sir, for your wonderful session. And for the audience and for the non-neuro sake, what is the safe drug which we can give for restless leg syndrome in our practice, if we find safe drug? Because you are abusing now that non-triptyline, non-adrenaline.
Safest drug, I would suggest, please use plain pregabalin or plain gabapentin. If you think of
Okay, I think that is a take-home message for the floor.
To use.
Safely, you can use pregabalin as said by sir. And thank you so much, sir, for an super session. Lot more questions to discuss, but I think due to the time constraint, we'll wind up the session.
Thank you very much, Dr. Srinivas, for the wonderful talk on restless leg syndrome. Thank you, chairpersons, for the wonderful update. I request Dr. Shivani Swami to present this certificate memento to our guest speaker, Dr. Srinivas. Srinivas? Yeah. Dr. Sabari Ravichandar, please come to the dais. Dr. Sindhu Raghugundi, Dr. Dina. Thank you very much for wonderful. Come on. Sindura. Dr. Deepika. என்ன சொல்றீங்க கொடுக்கலையா கொஞ்சம் இது மாறி இருக்கு நேம் மாறி போயிருக்கு அதனால சொல்லிட்டு வரல சாரி இப்போ நமக்கு வேற டேக் ஒன் சர்டிஃபிகேட் டெலிகேஷன் இல்ல அது கொஞ்சம் மாடிஃபிகேஷன் அப்போ உங்களுக்கு ப்ளூஸ் கொடுத்து அப்புறம் மாடிக்கலாம் சிவானி கூட சொல்லட்டுமா May I request Dr. Gayatri ma'am to receive the certificate from Dr. Shivani. Apra, Gayatri did a wonderful moderation for the topic, make sleep health a priority. So, Shivani, request to give the. Thank you. Over to Dr. Sridevi for the quiz program. Sridevi and Supraja. Yeah. Workshop announce பண்ணுவா அது நேம்ஸ் எந்தெந்த டீம் யார் யார் அனௌன்ஸ் பண்ணி
Just before the start of the quiz program, I'd like to just make an announcement to all the PGs here. So in this particular order, Dr. Mohan Dr. Ilakia, Dr. Ansia, Dr. Sudha, Dr. Sujita, Dr. Rakshana, Dr. Zeba, and Dr. Goli Sahiti. So these 7 people, you will be in the second station, which will be at the back end of this hall. Then Dr. Sanam, Dr. Manova, Dr. Amir Mustaq, Dr. Mutarasan, Dr. Darini, Dr. Isha and Dr. Shazia. You'll be in station 3, which will be to the front of the adjacent hall. And Dr. Alfia, Dr. Kripa, Dr. Nivedita, Dr. Mohana Krishnan, Dr. Dilipan, Dr. Karthikeyan, and Dr. Abarna. So you'll be at the back end of the adjacent hall. So station 1 is PSG, station 2 is DISE, station 3 is NIV, and station 4 is MAD. So in this order, and then at the end of 40 minutes, you'll be going in rotations, and you'll be attending all the 4 workshops. Yeah. If you need any clarity, please let me know. And if there's any other PG who's missed out, I mean, whose name I've missed out, then please let me know.
All right.
You're done? You're done? Okay, can I request all the postgraduates who've been announced to come forward, who've been selected for the quiz? I request all the postgraduates to come forward. Yeah. I request all the postgraduates to please come forward who've been selected for the quiz. Team A will sit here.
Team A here.
Team A.
Name
Dr. Sanam Vandana, Dr. Dileepan, please come here.
Team A. Sanam Vandana Dilip.
I know it's pre-lunch. Please make it fast. I think everybody else is also hungry. So please come. Team A will be here. Team B will be Dr. Goli Sahiti and Dr. Amir Mustaq. Team C, Dr. Kripa Jaiswal, Dr. Isha Gohini will sit here. And Team D, Dr. Karthikeyan and Dr. Nivedita. Yeah. I request the teams to introduce yourself. Please introduce yourself.
Good afternoon, ma'am. I am Dr. Dilip.
Which medical college?
I am Dr. S. Dileepan. I am from ACS Medical College. I am final year PG. ACS Medical College.
Okay, Dr. Dileepan from ACS Medical College. Yeah.
Good afternoon. This is S. Vandana from Chettinad Medical College, first year PG resident.
Good afternoon, everyone. This is Goli Sahiti from Chettinad, first year PG.
Good afternoon. This is Dr. Amir Mustaq Khan, first year PG from Chettinad.
Good afternoon. This is Dr. Isha Gohini, Chettinad College, first year.
Hi, this is Kripa, Dr. Kripa, first year from ACS Medical College.
Hi, this is Nivedita, first year from ACS Medical College.
Dr. Karthikeyan, final year from KMC.
So let's get started with the general instructions. All the audience, may I request all the audience to maintain absolute silence while the quiz is going on? Please, audience, cooperate. Maintain absolute silence. So you'll have 3 rounds. Round 1, which is a general round. Okay, 2 set of questions will be asked per team, and then the duration per question will be 20 seconds. Do we have somebody to time it? Yeah. And 5 marks if it is passed on to the next team, and 10-second timer will be there. Round 2 will be a buzzer round, 6 set of questions. We don't have a buzzer here, so you can just raise your hands. Okay, whoever raises your hands first will be given the chance to answer. And per question, it will be 20 seconds. And round 3, it's a rapid fire round, wherein each team will be asked 4 set of questions. Okay, each carrying 10 marks. And 5-second timer per question. Okay, are you all ready? So what is going to be the prize when you win? So we have the winner team who will get 7,000 rupees, and the runner-ups will get 3,000 rupees. So are you ready to fight for it? Please shout and say yes. Yes, okay. And also when you're answering, I want you to be louder, please. And do you have mics? Audience, can I go to them? Okay, can we start? Yeah. So my teammates, Dr. Supraja, Dr. Abraham, and Dr. Aprameya will assist me. Dr. Muthu also, yes, yeah. So are we ready? Shall we start? Do you all have the mics? Maybe you can just pass it on. Somebody, some volunteer, please pass on to the next team if at all, once they're done with that. Okay, we'll start with the round 1. The question for team A. Who first introduced the term obstructive sleep apnea syndrome? A. Gestow et al., Geliminal. C. Colin Sullivan. D. Nathaniel Clayman. Your time starts now.
Option C, ma'am.
Option C is incorrect. Option B is the correct answer.
No passing.
Oh, okay, fine. Okay, I think we'll not do the passing because of want of time. Yeah. So the second question for team B, who first recognized narcolepsy, cataplexy as distinct clinical conditions in 1880s? A. William Dement. B. Nathaniel Clayman. C. Jean Baptiste Gelagnon. D. Alfred Loomis. C. C is the correct answer. So team B will get points. So third question for team C, who introduced CPAP therapy as a treatment for obstructive sleep apnea in 1981? A. William Dement. B. Colin Sullivan. C. Christian Geliminal. Or D. Nathaniel Clayman.
B.
B is the correct answer. So fourth question for team D, who was credited in 1918 with linking obesity to Pickwickian syndrome? Option A, William Dement. B, Sir William Osler. C, Charles Dickens. D, Gestow.
Option B.
Louder?
Option B, Sir William Osler.
Yes, correct. So next question, set of questions for team A. The Association of Sleep Disorder Centers, ASDC, now known as American Academy of Sleep Medicine, was founded in which year? A. 1966, B. 1975, C. 1980, D. 1990.
Option D, ma'am. 1990.
That's incorrect. The correct answer is 1975, option B. Okay. When did this next question for team B? When did American Medical Association recognize sleep medicine as a subspecialty? A. 1985, B. 1990, C. 1994, D. 2000. C. C is the correct answer. Next question for team C. The first narcolepsy center was established at Stanford University in which year? A. 1946, B. 1955, C. 1964, D. 1970.
D.
Year, can you tell which year?
1970.
That's incorrect. Option C, 1964 is the correct answer. So next question, the last in the first round. Tracheostomy as a treatment of choice for obstructive sleep apnea was first used in which year? Question for team D. 1940s, B, 1950s, 1960s, or 1970s?
C, 1960s.
Yes, that's a correct answer. Next, moving on to the round two. Yeah, can we have the marks? Yes, the end of round one.
Group A, 0. Group B, 20 points. Group C, 10 points. And Group D, 20 points.
Yeah, Group B and D are leading. I think like Group A, you have to work hard. Okay, next move. Yeah. So we don't have a buzzer, so you can raise your hand if at all you know the answer. Okay. Can we start with the buzzer round? Yeah. So which of the following is a common site of collapse in patients with OSA? A. Nasopharynx and trachea, palatal and retroglossal regions, larynx and bronchi, epiglottis and soft palate. Group B.
D.
D is incorrect. So next, who showed the hands?
C. Anga D.
B. Option B.
B. Yeah. Tell the answer.
Retropalatal and retroglossal region.
Yes, that's the correct answer. Yeah. So option D will get the points. Next question. The primary neurotransmitter responsible for triggering and maintaining REM sleep includes A. Serotonin, B. Acetylcholine, C. Dopamine, D. Norepinephrine. Team C.
C.
C is incorrect. I think we'll ask only 2 teams to answer.
Okay. D.
Option A, serotonin.
Incorrect. The correct answer is B. Acetylcholine. Next question. Which classification system is commonly used during drug-induced sleep endoscopy, which is DICE, to evaluate pharyngeal obstruction? A. Stop bang, B. Malampati, C. Friedman, D. Oat classification. B. Yeah.
C.
C is incorrect. Quickly. Okay.
D.
Pardon?
Option D.
Option D. Yeah, it's correct. Can you expand it? What does it mean? Okay. Yeah, so I think you'll learn more about this in the afternoon sessions. So it basically shows like, the velum, your oropharynx, tongue base, and the epiglottis. That is what the Oat classification is. Moving on to the next question. Which of the following is a significant contributor to the hypertension in patients with OSA? A. Increased parasympathetic activity. B. Intermittent hypoxia leading to oxidative stress. C. Reduced cardiac output. D. Increased airway resistance leading to bradycardia. Team A.
Option B.
B is correct. Question 5. Women with the following condition have a higher risk of OSA compared to age and weight matched controls. A. Osteoporosis. B. PCOS. C. Endometriosis. D. Hypoglycemia. C. Yeah. Yeah, please answer. You should be quick. Otherwise, we'll give the chance to the other team.
Option C, endometriosis.
Incorrect.
Option B, PCOS.
Yes, that's the correct answer. The following gene polymorphisms are linked to increased risk of OSA except A. APOE epsilon 4, B. TNF alpha, C. LPAR1, D. PTGER3. So you have to rule it out. Which one? Except.
B.
Incorrect. Okay.
Option D.
B.
D.
D is incorrect. The correct answer is A. APOE epsilon 4. So we have come to the end of round 2. Can we have the scores at the end of round 2?
At the end of round 2, Group A, 10 points, Group B, 20 points, Group C, 20 points, and Group D, 40 points.
Okay. Group D is leading. So next we'll move on to the rapid fire round. So the set of questions, you'll be asked 4 set of questions. Please listen carefully and you should be quick enough to answer. Just 5 seconds time will be given. So Team A, here are your set of questions. Are you ready? The term polysomnography was coined by which scientist? Jerome Holland, Richard Carton, Hans Berger, David Brown. Which 2 major factors contribute to overall loop gain? Airway resistance, lung compliance, functional residual capacity and oxygen saturation, plant gain and controller gain, blood pressure and heart rate variability.
Option B.
B is incorrect.
Functional residual capacity and oxygen saturation.
It's incorrect. Yeah. What is one proposed reason for lower prevalence of OSA among premenopausal women? Increased lung volume, protective effects of female hormones, higher airway collapsibility, genetic predisposition.
Protective effects of female.
Yes, correct. According to ASM guidelines, in which patients should PSG be preferred over home sleep apnea testing? Patients with mild OSA with significant cardiorespiratory and neuromuscular conditions. C, patients without daytime sleepiness with habitual snorers with no other symptoms.
Option B, patients with significant.
Yes, correct. Yeah, 4 questions. So can we move on to the set of questions for Team B? Are you ready?
Yes, ma'am.
Team B, are you ready?
Yes, ma'am.
Yes. So which literally work for first described a character exhibiting symptoms of what is now known as Pickwickian syndrome? Great Expectations, Posthumous Papers of Pickwick Club, A Tale of Two Cities, Oliver Twist.
Ma'am, B.
B.
The posthumous papers of the Pickwick Club.
Yes, that is correct. So what does plant gain primarily reflect? The response of brainstem to carbon dioxide changes, effectiveness of breathing to eliminate carbon dioxide, efficiency of diaphragm in generating respiratory effort, the patency of upper airway during sleep.
Ma'am, C. The efficiency of the diaphragm in generating respiratory effort.
That's incorrect. Melatonin is secreted by which gland? Pituitary, thymus, pineal.
Pineal gland. C.
Pineal, correct. For home sleep apnea test, the minimal requirements include airflow, respiratory effort, oxygen saturation for at least how many hours? 2 hours, 3, 4, or 6?
6 hours. D.
Incorrect. It's 4 hours. So can we move on to Team C? Team C, are you ready?
Yes.
Okay, here are your set of questions. What is the anatomic location of REM sleep? Midbrain, pons, medulla, ras. Next question, what happens when loop gain is equal to or greater than 1? Breathing stabilizes and remains steady. It becomes unstable. Lung increase their functional residual capacity. Carbon dioxide levels remain unchanged.
It's C.
C is incorrect. If a patient has a negative first polysomnography but clinical suspicion for OSA is high, what does the ASM suggest? Second test, immediate titration of to CPAP, or use clinical questionnaire, or no further testing required?
C.
C is incorrect. How does acromegaly contribute to OSA? By reducing upper airway collapsibility through osseous and software tissue changes that narrow the airway, by increasing lung function and improving airway resistance through increased ventilatory control stability.
Option A, by reducing upper airway collapsibility.
That's incorrect. So next set of questions for Team D. Team D, are you ready? Team D? Yeah. Yes. So sleep spindles and K complexes are distinct brainwave patterns primarily observed during which stage of?
2.
Yes.
B, option B. Yeah.
Option B is correct, yes. Which neuromodulation therapy has been FDA approved for OSA patients who cannot tolerate CPAP? Vagus nerve stimulation, hypoglossal nerve stimulation, brainwave stimulation, deep brain stimulation, or transcranial magnetic stimulation?
Option A, vagus.
That's incorrect. Which of the following surgical procedures is most likely to benefit children with OSA?
Option B. Option B, uvulopalatopharyngoplasty.
It's incorrect. It's the adenotonsillectomy. So what is the name of the first medicine approved by US FDA for the treatment of moderate to severe OSA? Semaglutide, liraglutide, tirzepatide, or dulaglutide?
Option B, liraglutide.
Incorrect. Today we had the morning session, that is tirzepatide. Okay, that is the first drug which is approved in patients with OSA. Okay, you cannot talk about the obesity part here. Okay, can we have the scores at the end of all the 3 rounds? Yeah.
So
First is by Team D. Second is by Team B. First is Team D and B. Okay. Yeah. So the winners of this quiz is with 50 points, it is Team D. Okay, please, audience, give a big round of applause to Team D. And the runner-ups, it's a Team B. Okay, so with 40 points, not bad. So you want the prize money now itself or during the valedictory function?
So where should I give this?
Sir, yes, sir. Yes. So the winner team is Team D with 50 points. Can we request them on the stage? And I request Dr. Shivani ma'am to give away the prize money, which is 7,000. Yes. Team D, Dr. Karthikeyan, Dr. Nivedita. Dr. Karthikeyan from Keelpark Medical College, Dr. Nivedita, ACS Medical College. Yes. So please, audience, encourage them. Yeah, the runner-up team is Team B. Team B, Dr. Goli Sahiti from Chettinad Medical College, Dr. Ahmed Mustaq from Chettinad Medical College. They'll get the prize money, 3,000 rupees. So thank you so much. I thank my team, Dr. Supraja, and the team from Chettinad, Dr. Ibrahim, Dr. Aprameya, and Dr. Muthu, who all helped us with this quiz. There'll be half an hour lunch break now, and immediately please assemble back for the workshop. Okay? Yeah. I think how much time did I take? Not much time. Yeah.